The meeting of the House Appropriations Subcommittee on Health and Human Services will be called to order. Clerk, will you please take attendance?
Just let you know, Rep. Kuhn and Rep. Steele will be on Zoom. Chair Morse,
Here.
Vice Chair Martis, Representative Hood, Representative Braybeck, Representative O'Neill.
Present. Present.
Thank you, Representative. Representative Puri, Representative Farhat, Representative Price, Representative Skaggs, Representative Snyder, Vice Chair Green.
Present.
Representative Bolin.
Here.
Representative Meerman. Representative Kuhn.
Here.
Representative Steele.
Here.
Madam Chair, you do not have a quorum.
Thank you, Clerk. Good morning, everybody, and welcome to our meeting regarding public comment on the 2023-24 budget for the Health and Human Services. We're happy that so many of you were aware of this meeting, and we're glad to welcome you today to share your testimony. So we are asking that everyone please limit your testimony to about 3 minutes. There may be the opportunity, you may get some questions from the committee. And I would just like to note that, yes, we have some committee members online and some will be coming in. This is our in-district work period, so that's why you don't maybe see as many here on the dais today. But we're glad to have you all, and we will start calling you up individually by name. We also have cards up near the front, so if you haven't filled one out yet, but you would like to testify, that's how we're going to call you up here. So please make sure you fill out a card and bring it up to our staff here, and they'll get it to us. So first, we're going to call up Colleen Allen from the Autism Alliance of Michigan.
Thank you so much. Can you hear me okay?
Did you turn the mic on?
There we go.
Okay.
Thank you so much. I appreciate the committee, and I will be very quick. My item relates to the autism service line. Within that budget, there is funding at 1.025 for the Autism Navigator services, which we run through the Autism Alliance of Michigan. And we have been advocating for increase in that funding line, almost to actually double it by $1 million, mainly due to the demand. So we have gone from serving 2,000 families a year to 4,000 last year. Our resolution rate in terms of how we connect families to services, provide consultation, has been in past years close to 80%. That has dropped because we have so many families that need that service now. So very simply asking for an increase in that line budget so that we can continue to help families resolve issues relating to the earliest diagnosis to finding a job, transportation, and other services. And then lastly, secondary request, second in priority would be to establish through a $500,000 appropriation, a specific crisis navigator service. We know that this is critical right now in Michigan with children and adults landing in emergency rooms, getting caught up in law enforcement due to escalating severe behaviors. And we believe that we could provide a service that could circumvent some of the escalation and really begin to address those issues.
Seeing no questions, thank you so much.
All right, thank you.
Next, we have David LaLumia and Deanna Solomon from the Area Agencies on Aging from Detroit. Just please push the button for the mic there in front of you. Thank you.
Good morning.
Madam Chair and members of the subcommittee. I'm Dave Lalamiya. I'm the Executive Director of the Area Agencies on Aging Association of Michigan. And with me is Deanna Solomon from the Detroit AAA Agency. We appreciate the opportunity to be here this morning and to speak with you about some of the issues in the FY24 executive budget that are important to area agencies on aging. In Michigan, there are 16 area agencies on aging that serve all 83 Michigan counties. AAAs were established in 1974 by the Federal Older Americans Act to create comprehensive local systems of care and to support older adults and people with disabilities in their own homes. In addition to the Older Americans Act, in 1981, the Older Michiganians Act was passed, and this act provides state support for home and community-based services and incorporates the mission of AAAs into state statute. AAAs braid the Older Americans Act funding, the Older Michiganians Act funding, and the Medicaid My Choice waiver funding into a seamless system of care so that a person in the community does not have to be Medicaid eligible in order to be served by the My Choice program. And we're able to design programs for local citizens irrespective of their insurance status or their ability to pay. AAAs are agents or managers of the My Choice waiver program, and My Choice is a program that serves individuals who are nursing home eligible and provides services and supports to maintain those individuals in their own homes. Waiver agents, AAAs, have been designated as managed care organizations, and technically we are, for Medicaid purposes, known as prepaid ambulatory health plans, PAHPs, and our contract to provide My Choice services with the state is a capitated at-risk contract, so we are truly managed care organizations. The My Choice program served over 16,300 individuals in FY22, and the average cost of serving a My Choice enrollee is around $88 a day, and it's significantly lower, more than $200 lower than the average cost of supporting an individual in an institutional setting. So there's a tremendous amount of savings to the Medicaid program that are produced by My Choice, in addition to supporting people where they really want to be and live, and that is in their own homes. So I would like to turn this over briefly to Deanna Solomon from the Detroit Area Agency on Aging to talk a little bit about AAA services in the Detroit metro area.
Yes, thank you, Dave, and good morning to Chair Rep. Morris and to the committee at large. We want to thank you for your leadership on behalf of my president and CEO, Mr. Ronald Taylor. I am Deanna Solomon with the Detroit Area Agency on Aging, and we serve 9 cities: Detroit, Highland Park, Hamtramck, Harper Woods, and the 5 Grosse Points in our region, and have for 42 years. We have roughly 300,000 caregivers in our region, and that's pretty indicative based on 1 in 5 Americans that are actually caregiving for family members. And the AARP studies from 2021 show that 20% of a caregiver's, 26% of a caregiver's income is spent out of pocket caring for family members. At DAAA, we have a robust caregiver support program, and we are busting at the seams. Our caregiver supports provide education, assessments, support, advocacy, and we certainly work internally with our base of older adults that are receiving direct care, and we work externally in the community. We also support our direct caregivers that work with our providers on an as-need basis. And I wanted to at least provide a snapshot of just the level of, I guess, intensity and need that caregivers have in our region, in that we work with caregivers primarily because we have older adults that may have dementia, may be hospitalized, dealing with multiple chronic illnesses, and the caregivers are the voice. They are the conduit. They help us provide seamless services to deliver those services to older adults in need. And so they really have been, most caregivers tend to be a lifeline for the older adults that they support. And so we just ask for you to take a look at the presentation and take a close look at the presentation and the ask for additional support for caregiver funding.
Okay, thank you for your testimony this morning. So your specific asks that you're here on behalf of are in this paperwork, is that?
Yes.
Okay.
Yes, Representative.
Because-
There are two that we want to highlight. One is as Deanna has just mentioned, the Caregiver Resource Center proposals. Family and informal unpaid caregivers provide an enormous amount of long-term care. They help people stay in their own homes and out of institutional settings. We are proposing a Caregiver Resource Center project, and a Caregiver Resource Center is really a set of virtual and in-person resources across the state located in each of the AAAs, which provide support to caregivers. The research estimates that there are more than 23 million citizens of Michigan who meet the definition of family or informal caregiver, and we think this would be a transformational program. We're asking for a one-time appropriation of $16.8 million to support caregiver resource centers. The other piece we would like to just punch up briefly is the direct care worker item, and we support the governor's recommendation for a $1.50 an hour increase for direct care workers, but we don't think that that's enough, and we are part of an essential jobs, essential care training and work group coalition who's recommending a $4 an hour increase for direct care workers in FY24. And we support this recommendation. It's essential, direct care workers are essential to maintaining quality of care and reaching the number of people that we really have to reach in their own homes. So, you know, we would appreciate that the subcommittee is looking at the direct care worker item and moving closer to the recommendation of the EJEC coalition. We also support the recommendations of the Silver Key Coalition that you're going to be hearing from, I believe, today, and also we support the recommendation to improve and increase funding for the long-term care ombudsman. And Deanna, did you have anything else that you wanted to add?
No, I think that about covers it. Any other questions?
All right, seeing no other questions, thank you so much for your testimony today.
Thank you.
Next, we'll call up Aaron Rush, Megan Hennessy, Carmen Wargel, and Heath Lowry. Lori Kitchen Bushel. I'm sorry. Oh, one at a time. Okay. Aaron Rush, come on forward. Sorry about that. YWCA Kalamazoo.
Hello, I'm here today representing YWCA of Kalamazoo. My name is Aaron Rush, and I work as a public policy coordinator for the YWCA. My purpose for speaking here today is to ask that this upcoming budget make survivors of domestic violence and sexual assault a priority. Today, I hope to be able to cover a little bit of what the YWCA Kalamazoo does. I then want to highlight the struggles that YWCA Kalamazoo and the state faces with the current levels of funding for survivors. And then lastly, I want to raise up the statewide ask of $30 million for survivors. YWCA Kalamazoo is a staple institution of Kalamazoo and Southwest Michigan, and we've been dedicated to serving survivors for years. At YWCA Kalamazoo, we provide comprehensive services for survivors of domestic violence and sexual assault. Such services include, but are not limited to, shelter, transitional housing, advocacy, therapy, legal services, and that's just to name a few. In 2021, YWCA Kalamazoo provided services to 1,006 survivors of domestic violence and sexual assault. This included providing 39,728 hours of shelter, which is over 1,600 days of shelter. YWCA Kalamazoo also provided 185 days worth of free therapy services. These numbers really only begin to scratch the surface level of the many essential services that YWCA Kalamazoo provides. Providing such essential services does have a cost, and the need for these essential services are rising while funding is decreasing. Over the past 4 years of available data, Michigan has seen a significant increase in domestic violence cases, this trend only being exacerbated by the recent pandemic. Michigan service providers serve on average between 2,600 and 3,100 people every day. And while these needs are increasing and hardworking programs are serving thousands of survivors every day, federal funding to provide these services is declining. Michigan has seen over a $50 million decline in VOCA funding from its high in 2018. Despite such declines, Michigan has not stepped up as a state to properly fund the programs that provide essential services to survivors. Because of this lack of funding, Michigan lets on average between 200 to 400 requests for service go unfulfilled every day. These numbers will only get worse with the expected cuts in funding for programs. At YWCA Kalamazoo, a decrease in funding would drastically worsen the struggles we already face. Staffing programs and retaining staff is already difficult and would only worsen with reduced funding. Our ability to provide robust client assistance is already negatively impacted by current funding levels and restrictions on funding. Reduced funding would only further hamper and restrict our best efforts to provide these essential needs. Without an investment in domestic violence and sexual assault programs from the state, survivors will be hurt. YWCA programs will struggle to provide services due to no fault of their own, and that's including YWCA of Kalamazoo. The number of unfulfilled requests for services will only increase, and this could have catastrophic consequences for survivors. This is why we're asking, as a collective voice, for $30 million in this upcoming budget to support survivors. Such an investment will help push Michigan in the right direction to become a place for all to be safe, happy, and live their life to its fullest. Thank you very much.
Any questions? No? Thank you so much. Next, we'll call up Megan Hennessy.
Good morning. I'm Megan Hennessy. I'm the program director at Resilience Advocates for Ending Violence based in Holland. We're a sister agency similar to the YWCA. I've also had the privilege of working at a child advocacy center in Washtenaw County and also dual domestic and sexual violence agencies in Jackson, Ottawa, and Allegan counties. My purpose in speaking with you today is to paint a bit of a picture behind the numbers that Erin had just referenced. What we're asking for is for funding for domestic and sexual violence survivors across the lifespan. And so I want to give you some quick examples of some of the stories behind those thousands of numbers that we're serving every day, because these services happen in private. These crimes are usually by design perpetrated in private, and therefore they're not often seen like you would see a fire department putting out a fire, for example. There's no one crowding around a burning building to witness what these services look like. So to paint a picture, my first example, these are all survivors that I worked with in my career at both child advocacy centers and dual domestic and sexual violence agencies. My first example is a 2-year-old who was sexually assaulted. 2-year-olds are too young to tell us about what happened, and the only reason this toddler's protectors knew about the abuse was because a stranger, a Good Samaritan, witnessed the assault with his own eyes. The toddler visited a child advocacy center where she had a medical exam, and the toddler's parents met with the therapist to process their grief and trauma. The therapist also helped them emotionally prepare for court, provided them with information on how they could best help their child. And when this former 2-year-old grows old enough to learn about what happened to her, and if her local CAC has not been shut down, a counselor will be available to her to understand and help her make sense of what happened to her at no cost to her and her family. And that's going to be different for her at different developmental stages as she grows. Example 2 is another child. She was probably 6 years old when her father started raping her over the course of a decade. When she was 16, she found the bravery and strength to tell her mother about it. A child advocacy center had a trained forensic specialist interview her in a trauma-informed way that considered her needs first and also collected information for prosecution. All the professionals involved in that case, including a CPS worker, a detective, a prosecutor, and a counselor, watched from behind a one-way mirror so the teen did not have to share her story multiple times. Both before and after the interview, the multidisciplinary team joined the mother around the table so they could collectively plan for the teen's care and answer the mother's questions. The teen went to the Child Advocacy Center on another date for a medical exam where a pediatrician looked for evidence and discussed the teenager's concerns and questions about her body in an age-appropriate way. She was worried that her body was damaged from the abuse. A trauma-informed therapist worked with the teen. Counselors met with each of her siblings. A counselor met with her mother to process her horror and discuss how to best support her children. And when a therapist learned that the teenager was worried about her spiritual purity, she got each of the family members' permission to reach out to the family's pastor to facilitate a conversation for the child's spiritual care. Moving on to an example of someone a little older. A college student who was raped at a party was brought into a sexual assault program in the middle of the night by her 2 confidants who had also been at the party. She met with a staff nurse to have a forensic exam. These exams serve 2 functions: 1, collecting evidence for what's sometimes known as a rape kit, and 2, to provide medical care. An advocate was also in the room to support the survivor. This advocate reminded her to breathe, reiterated the choice that she had during the exam, and distracted her when she requested and held her hand. Afterward, the advocate also met with and consoled the friends who were in the waiting room and gave them concrete ideas and things to say so they could support their friend. Another one, a man told his adult wife he had been sexually abused as a child. She was the first one he had ever told, and he had held onto that secret for decades. At a sexual assault program, he was able to face and learn to cope with his PTSD with a therapist. The counseling helped him put down the burden of the shame he had been carrying for so long, strengthened his marriage, and removed his suicidal ideation. Another example, a woman's husband held a gun to her head and told her that if she left him, he would kill her and her children. She escaped in the middle of the night and met a shelter worker out in public who brought her to a confidentially located shelter. She had left with just the clothes on her back and her children's backs. So shelter advocates worked to connect her to resources to rebuild her life, everything from obtaining medication and copies of her children's birth certificates to finding safe and stable housing free from violence. Having access to emergency shelter probably saved her life, and these shelters across Michigan regularly prevent intimate partner homicides. And finally, my last example, an elderly woman who, while on hospice, was sexually assaulted by hospice staff. She requested to have a sexual assault nurse exam in the hopes that the perpetrator could be held accountable, even though she knew she wouldn't live to see the end of the investigation. I share these difficult to hear examples because it's important to note that these scenarios are not uncommon. 1 in 10 children are sexually abused by the age of 18, and a CDC survey estimates that about 31% of Michiganders experience some kind of intimate partner physical violence, sexual assault, or stalking. Those who have benefited from these services are constituents in your community who you know, though they don't tell their members of their community in the way that they would mention that they were helped by a fire department or a EMS. They're your friends, colleagues, neighbors, church members, Domestic and sexual violence are severely underreported crimes, and it's essential that we continue to provide support to those who need it. In Michigan, the demand for services provided by agencies offering support for victims of domestic and sexual violence far exceeds their capacity. These organizations often have wait lists for counseling and advocacy, and they're unable to accommodate all those seeking shelter. Unless these agencies receive sustainable and adequate funding, many of them will have no choice but to close their doors. The absence of funding would leave these agencies unable to intervene in the metaphorical fires that are ravaging the lives of survivors in our communities. If this were to happen, future generations of Michiganders who are victimized over the course of their lifetime would be denied the chance to access vital services that enable them to become survivors. Please invest in Michiganders' access to these services. Thank you for your time.
Thank you, Megan, for sharing those important stories that, while they're hard to hear, we need to hear them. So thank you.
Thank you.
And the details of this ask were submitted alongside written testimony from Denise Berry as well, if you would like to see the details.
Yeah, I was going to ask, I know we have a number of people talking on the same subject, but is that 30 million for 1 year, or is that, what does the 30 million entail?
It is to compensate for the expected decrease in VOCA funding from the federal level, but also to establish stable funding for these programs who have seen dramatic decreases over the past several years.
Okay. So you wouldn't anticipate that they would be asking for 30 million ongoing every year, but this is seed money to some extent?
To some extent, yes.
Okay. All right. Thank you so much, Megan.
Thank you.
Next, we'll call up Carmen Wargel and Heath Lowry from Turning Point.
Good morning, and thank you for letting me have a chance to talk with you. I am Carmen Wargel. I'm the Senior Strategy Director at Turning Point in Macomb County. Our mission is to empower survivors of domestic violence, sexual violence, and human trafficking through comprehensive services and resources while advocating for community action to end oppression and violence. Turning Point was founded in 1980, and so we've been serving survivors in Southeast Michigan for well over 40 years. One way to tell you the story of our work and its value is through numbers. From October of 2021 to September of 2022, we served 2,683 clients, took 4,528 hotline calls, sheltered 252 survivors and their children, supported 415 people with trauma advocacy, performed 254 forensic exams, assisted with 1,647 personal protection orders, provided legal advocacy to 107 people, and provided 178 community presentations. Another way to demonstrate our value is through stories. Whether through momentary contact or ongoing supports, survivors tell us over and over and over again how our services save their lives, change the trajectory of their children's future, how our educational presentations validate their lived experience, or how our systems change work makes the community safer for them. Our newly created program to house survivors of labor and sex trafficking fills a gaping hole in our community's programs because we house survivors of any kind of trafficking, regardless of gender, sobriety, or sexual orientation. We allow people who have been trafficked to live with their minor children, and we don't impose a curfew. Our programs offer survivors of domestic violence, sexual violence, and human trafficking a chance to be treated with dignity as a whole person who deserves to shape their own future. Our work is essential, but our funding streams do not reflect our value. Turning Point is one of the best funded organizations in the state. We are deeply grateful to the state and federal government, private donors, and other granting institutions for what we have. But still, we have to turn away survivors almost every day from shelter, counseling, housing, or other vital services. Like everyone, we struggle to retain and hire because our wages are well below the going rates, even within comparable fields. We are constantly on our heels trying to figure out how to fund what survivors need. I am asking you today to commit to a long-term, stable funding plan like our surrounding Great Lakes states, most notably Ohio. The money allocated by the governor is not enough to meet the need for long-term, stable funding. Survivors deserve a predictable and stable investment in their lives by the state of Michigan. Please support the funding plan brought forward by these three coalitions to fund services for survivors of violence across the lifespan. Thank you.
Thank you so much for your testimony today. Next, we'll have Lori Kitchen-Bushel.
Hello, good morning. You can hear me. So I'm Lori Kitchen-Bushel. I'm the Executive Director of First Step. Like my colleagues before me have spoken to very personalized stories, I'm going to share a little bit more about the load the staff is carrying across the state. I am the Executive Director of First Step. We are the comprehensive service provider for domestic and sexual violence serving Wayne County, including the city of Detroit. We're one of the oldest and one of the largest agencies doing this work. And the domestic and sexual violence infrastructure across the state of Michigan is in crisis. Our staffs have carried the load of our community acutely through the onslaught of the COVID pandemic with no relief in sight. I want to remind you that when everything shut down, violence got worse. Our staff was still going into shelter. They were virtually schooling children in shelter. They were risking their own lives and their own health. They were still going into police departments. They were still working directly with survivors in extremely unsafe situations and have continued to. They are there face-to-face in court and police departments with assailants while the indicators for this violence become increasingly lethal. We are seeing reports of weapons and strangulation across Wayne County that is significantly increased since prior to the pandemic starting. We interact and serve 6,000 to 10,000 survivors annually in Wayne County and the surrounding area alone. Before March of 2020, we received approximately 100 calls a month from families trying to leave violence in their home, and we did not have space for them. That is 100 families a month who finally had a moment to make that call to leave their home, and we had to tell them we were full. We would refer them out of county to Haven, who's full, to Interim House in Detroit, who's full, to Turning Point in Macomb, who was full, to Safe House in Washtenaw, who is also full. It was 100 families a month before the pandemic. We are now turning away 200 families a month calling for shelter because we have no space. There is not enough beds. To respond to the huge need, First Step is embarking on opening a second shelter in Wayne County on the east side of Detroit, which would help build capacity for the entire southeastern Michigan region, so many survivors don't have to be displaced from Detroit and Wayne County by having to seek shelter further away. However, as we approach this project and are very close to signing our lease, we are now facing many discussions around funding cuts in many of our current funding streams. Not only are cuts coming from the state and federal grants, but private giving is decreasing. In the first quarter of this year alone, we have seen almost $200,000 of our foundation and donor giving not renewed due to concerns with the economy, inflation, and stock market value. That represents 1/5 of our philanthropy giving that we raise every year. We do not have resources to meet all the needs of survivors. We do not have enough beds to house them safely. We cannot afford the level of staffing needed, and we are seeing retention issues across the state because staff are burnt out. We do not have enough funding to pay them, even to maintain basic decency against the current state of inflation. Recently, we received several flower bouquets donated to our shelter from a funeral of a teacher who was killed by her boyfriend. A thoughtful gesture from the grieving family, but a reminder of the reality that this is the consequence of us not having the resources we need to serve everyone who desperately needs our services and provide prevention services. This is what it means to not have enough shelter beds, to not have enough community response advocates, resources, and staff to serve the immense and rampant violence in our communities. At a minimum, the state needs to mirror the leadership of other Great Lakes states that invest over $80 million into agencies like ours. Ohio just allocated $20 million on an ongoing basis for predictable, capacity supporting, and stabilizing dollars for this core work. May it not be taken for granted that one of the primary reasons people end up homeless is because of violence and abuse in their home. A safe home free from violence and assault is a core foundational need for stable and thriving families and communities across our great state. Thank you.
Thank you, Lori. Appreciate your testimony. And lastly, on this subject, we have Sarah Prout-Rennie.
Looks like she hasn't quite made it yet.
Okay, we can set hers aside, and if she gets here later, she can.
Thank you.
All right, thank you, Heath. Next, we have Philip Berquist, Michigan Primary Care Association.
Good morning. Philip Berquist, CEO of the Michigan Primary Care Association. Thanks for taking the time for us to speak with you this morning. MPCA's member health centers operate over 370 service delivery locations throughout the state of Michigan, providing care to about 715,000 Michigan residents. Community health centers, which are sometimes called by their more formal name, federally qualified health centers, are to deliver primary care and other integrated health services, including oral health, behavioral health, substance use care, and more, regardless of a patient's insurance status or their ability to pay. Across the state, health centers work to overcome geographic, social need, cultural, linguistic, and other barriers to care. They provide supportive services like health education, transportation, community resource connections, and they use systemic improvement approaches to always be delivering the best quality care they can. Over the course of the last several years, health centers have operated and navigated challenges in the pandemic as public health partners, delivering services like vaccines and testing, while also adapting their core healthcare services in a very different environment. And today, much of their work looks a little bit like normal again, and some of it doesn't. And one of those most lasting changes is cost. From the cost of maintaining facilities, to the gloves that a care team member wears, to the personnel salaries to pay folks to deliver services, everything is meaningfully more expensive to deliver services today. Really good example of that is personnel costs. So annually, personnel costs have gone up $44 million a year. That isn't to expand services or add staff. It costs $44 million a year more to pay the same care team members as it did 3 years ago. That increase really does represent rising wages, workforce challenges, but it's a good example of how costs have changed over time. Two of the most common misconceptions about health centers is that they receive enough federal funding to make up for low insurance payments, and that Medicaid payments to community health centers cover their costs. But unfortunately, neither one of those things are true. In most health centers, federal funding accounts for about a quarter of their budget, so really a very small portion. And in the Medicaid program, health center payments are adjusted only a small amount each year. A really good example would be in 2022, payments were adjusted 2.1%. Inflation for that same period was over 3 times that amount. Research from Health Management Associates sums this up in one single number. For every Medicaid service delivered by a community health center, it costs $61 more to provide the service than the health center is paid by Medicaid today. And unfortunately, recent investments made in Medicaid rate increases by the legislature haven't impacted health centers because they're paid in a unique payment system. To maintain the services that 1 in 14 Michiganders are relying on, health centers need an ongoing appropriations investment to raise their Medicaid rates. Filling the entire gap between Medicaid reimbursement today and the cost of delivering services would be about $112 million annually. That's a big number, and likely not one we're going to get to in 1 year, but we're looking forward to working with you to explore what can be done to this year to ensure Michigan residents continue to have stable access to care. And stable access to care really is what's at stake. Looking beyond payment rates and to how care can be reimbursed, it's become clear that volume-based payment in healthcare services is limiting innovation. Volume-based payment models reimburse providers like health centers based on the number of services we provide instead of the services or healthcare team members that are most effective in supporting a person's healthcare needs. Currently, health centers are paid in the Medicaid program through something called the prospective payment system, and that has some value-based aspects, but it's still based on the number of patient encounters that a health center generates. That PPS volume-based structure limits innovation because health centers have to design the services they deliver around what can be reimbursed. Otherwise, that service is not financially sustainable. Generally, the things that are reimbursed are traditionally licensed clinician visits like physicians or dentists. Otherwise, they're not reimbursed by Medicaid. Using a population-based alternative payment model, or an APM, would delink health center payment from volume, allowing greater flexibility to provide team-based care and meet patients' needs. It would offer better financial stability and some relief from the administrative complexity of the current payment approach. Supporting that transition for all health centers statewide would be a one-time cost of about $55.8 million, and that would include intensive staff training, new workflows, new pathways for how services delivered, technology adaptation, as well as one-time expenses in DHHS to implement the new approach. We believe those one-time federal dollars could be used to fund this expense during that transition to a population-based APM, and that would be a truly transformative investment in the future of community health centers alongside an appropriate Medicaid rate increase. Thanks for the opportunity to speak. Happy to take any questions.
Seeing no questions, thank you so much for being here today. Next, we have Rosalie Austin, Advocates for Mental Michigan Youth, it looks like. Rosalie? No? Oh, okay. So then we have Angela Hayes from Providers for Change. Come on up and please turn on the mic.
Hello. Hello. Hi, I'm Angela Hayes, and I'm here from Providers for Change in regards to the child care budget. I want to speak on a lot of things, but I'm only going to speak on one. And the main thing that I want to speak on is the funding. So we're set to go back to our original rates in September of 2023. It's not enough money. We make less than minimum wage as child care providers. And you guys continuously want us to give raises. Where are we getting this money from? It's not enough money. $6 to take care of a child, $6.35 an hour. It's no way we're going to survive. And then the governor now has something where they want to open up 1,000 child care centers by 2024. Where's staff going to come from? Because we're already struggling to pay our teachers. So I don't understand, there's different budgets, like the GSRP budget is out of the Department of Education. It's a Title I funding. Well, their programs are in our programs. We're licensed. We're the centers, the facilities that they're bringing the programs into our centers. Why can't we get that same funding? That's all I want to say.
Thank you, Angela. So next we have Michelle Massey Barnes from the Advocates for Mental Health of Michigan Youth. And there will be, I understand, a number of people on Zoom as well who are interested in testifying. So if Michelle, if you can kind of lead us through who's here with us today.
Thank you so much for having me. My name is Michelle Massey Barnes. I live in Jackson County, and I am a co-director and co-founder of Advocates for Mental Health of My Youth. We are a grassroots parent advocacy group. We've come together because we have children with what Michigan calls severe emotional disturbance, or SED for short. There's a special Medicaid waiver for children with SED. It's called the SED waiver, and it's a waiver that means without intensive home and community supports, these children would be hospitalized or institutionalized. It's not what any of our families want, but it is what most of the families that you will hear from today are experiencing with their children. I'm explaining this to you because we're not coming to you as parents with children with low or moderate mental health needs. We are parents with children with the most intensive needs in the state of Michigan. We have a lot in common, but one thing that we have in common is that the community mental health services that we are receiving, they're not helping our children. Sometimes the services are actually making things worse for our families, and they're causing us more distress. I knew that I was going to need help navigating the public mental health system when we first entered it. I knew I was going to need allies, support, and even backup, because sometimes it honestly feels like the system is working against us. The more my family advocated for the help and support that we needed, the more our services were getting cut. Mobile crisis units started to refuse to respond to our calls, and we were singled out and told that our child had to have a specific assessment done by a nurse, even though this was not a policy of our CMH. I don't know what most people call that, but I call it discrimination. It was impossible to navigate this system alone. If you would like specific examples of what makes it so impossible, please feel free to reach out to me. I'd love to have coffee with you or Zoom coffee and tell you about the 3.5-month CPS investigation that we went through because of what community mental health was falsely reporting to Child Protective Services. At the end of the investigation, nothing was substantiated, but the CPS investigator told me the best advice she had for us was to leave community mental health because CMH was more interested in fighting with me, the hands-on mom, than helping my child. Our grassroots parent advocacy group hit the ground running. We spoke at the Appropriations Subcommittee meeting last year, and you will probably hear from many of us again today, and I think you will realize that nothing has changed except for our advocacy. In the last 2 weeks alone, we have helped 24 families connect with their state representatives, 20 different state representatives. Some of you are even on this committee, and thank you to those of you who have already stepped in to help. We have over 500 parents in a private Facebook group, and the truth is we cannot keep up with the stories. We can't keep up with the crisis. We can't keep up with the desperate pleas for help. What we need you to understand is even though you've heard from 24 of us, there's so many of us that you haven't heard from. You're not hearing from families that don't have discretionary income for internet access or mobile devices. You're not hearing from families that have English as a second language or families that are working so hard to make ends meet that they're working instead of surfing Facebook looking for secret advocacy groups that most people don't even know exist. So we're coming to you today because one of our asks is for a mental health navigator program that will help all families get the support that they need and will put their experiences front and center. We need navigators that understand how the mental health system is actually working, and not navigators that assume that the system is working the way that it should be working. There's a huge difference. We need this program to ensure that our complaints are being investigated and corrected. Most of all, we need parent voices included in the role of oversight and accountability, because the truth is, if the distress levels of families are not decreasing, the complaints have not been adequately resolved. We believe the Mental Health Navigator program can fill both of these roles. We know this is something that MHAM has asked for, general fund dollars in the amount of $2 million for a child and youth navigator or advocacy service. We have a working model as advocates for mental health of my youth, and we would like to be collaborative partners backing this request for funding and backing the development of the program. Thank you so much.
Thank you, Michelle. Do we have any families on Zoom that wanted to give their testimony?
So there's a couple of us in the crowd,
Okay.
and then there might be a couple people on Zoom, but the people in the crowd are co-founders, so it would be great if we could go first.
Okay, go right ahead. And please introduce yourself and your organization.
I just turned it off. Thank you. My name is Rachel Kusheri Murray, and I'm with the Advocates of Mental Health for My Youth. And I'm a co-founder and a director and also a resident of Eaton County. My son has a waiver into Medicaid for severe emotional disturbance. The hardest decision I ever had to make in my whole life was to send my child out of state to receive the mental health treatment that he needed. And the second hardest decision I ever had to make was to go into debt over $250,000 to pay for it. My family has seen how this mental health system functions as it is, and I want to help you to understand what our families are dealing with. Children like mine and the families that you're going to hear from today make contact with the state of Michigan through the schools, CMH, child welfare, and juvenile justice. And with so many access points, you might think that it'd be easy to get help, but it is actually the opposite, and the stakes are high, because when families like mine don't get the help that we need, we're at high risk for losing our children to the courts and to foster care. And things go wrong a lot for families like mine. That's why our foster care system and our juvenile justice system is bursting at the seams right now. So you may not have known that this was happening if you're only talking to the department heads, but in the last year, we've connected with over 500 families living in crisis every day, and the stories are strikingly similar. Everyone's fighting to keep their kids and families safe while trying to avoid abandoning their children to foster care or jail. So I invite you all to follow our group on Facebook at Mental Health for My Youth so that you can see the stories for yourself. It's true that the dismantling of the mental health system in the 90s and the constant defunding of all of these departments have contributed to this situation. And we're starting to see the funding increase for individuals with low and moderate mental health needs, and we appreciate that, and we fully support and encourage it, because prevention is always the least expensive option. But we still have a whole population of children and adults with severe and complex mental health needs that are languishing. It's not enough to wait weeks or months to see if a crisis will resolve itself and then barely stabilize a child before sending them home with no support. That's what's happening now. And it's putting lives at risk all across Michigan. So instead, Michigan needs to properly fund mental health programs that are meaningful. We need to attract specialized talent to the state and provide intensive and ongoing training to build the expert knowledge base within our state. We must open cutting-edge treatment facilities that are more than just beds or numbers of beds, but provide critical, specialized therapeutic care that is holistic and suited to condition. That's what exists in other states. It doesn't exist in Michigan now. And we must fund that treatment to be completed so that it can prevent and reduce reoccurrence. And other departments need to be involved in this too, with the funding for mental health. So we need to properly fund juvenile justice so that children who are pushed into our justice system get the proper treatment suited to their condition while they're incarcerated. That's not happening now. And we also need to fund cooperation and coordination between the departments so that services can be seamless with proper transition plans when children move between departments. So like technology like OPICA could help with that. And lastly, something that doesn't cost anything is we need strong insurance parity laws so that insurance companies can't weasel out of paying for treatment that is medically necessary and covered under the plan, like what happened to my family with Anthem Blue Cross Blue Shield. It's been decades since the dismantling started, and it has been ongoing. Michigan has some of the worst statistics in the nation regarding mental health care, but you all can change that. You can make us a leader in the nation. Please hear the voices of family who know this whole system better than any expert within one department could. We are here to help you. When I made the decision to send my child out of state for his mental health treatment, people accused me of wanting him away from me. Nobody would have said that same thing if I had sent him for cutting-edge cancer treatment. He's back home now, and he's doing so much better. He's improving every day, but my family shouldn't have had to have gone through that. Families who cannot access debt shouldn't have to send their kids to jail or a foster home instead of treatment. Those children deserve to be well too. So let's build a system that we can all be proud of. Thank you.
Thanks, Rachel. Is this on? I see the red light. Okay. So my name is Laura Marshall. Thank you for allowing me the opportunity to speak with you. I'm just going to share a little of my family's experience with navigating community mental health services. I'm going to tell you about my middle son, who's currently 14. We started our journey with community mental health when he was a third grader, so he was 8 years old at that time. My son has a significant number of different mental health diagnoses, including ADHD, oppositional defiance disorder, reactive attachment disorder, and then there's some argument between whichever doctor you're speaking with as to whether or not pediatric bipolar actually exists. But he does have that diagnosis from one. What that looks like in our home is that days were just endless defiance. Every suggestion, something simple as please wash your hands with soap, please bring your clothing down so you can wash it, or we would wash it for him, brush your teeth, that sort of thing, would literally erupt into this aggressive episode. We dealt with daily anger and aggression, which often became destructive or assaultive. We literally had to remove everything from his bedroom, and even then, we didn't realize his closet shelving was removable, and it became literally a weapon. Splinters of pieces of wood from things that he would break, structures on the walls would then become, items that he would throw at us, and that sort of thing. The level of aggression constantly just kept us all at this base level of just trying to maintain safety. We absolutely tried to use community mental health in terms of their emergency response. You're supposed to call the crisis mobile line, and we were denied any help from that line on more than one occasion. We would call his therapist, we would call the on-call, and essentially what they always told us was, call the police. And so that's when you're trying to maintain safety in your home, what else do you have as an option? You call the police. So because of the number of times that we had to involve the police, my son then started to have placements within the juvenile detention system at one point. He was sitting in juvenile detention for 6 solid months. Make no mistake, there is no counseling or therapy available. It's child jail. And so they just, they sit and pass away the hours. And you're forcing your child then into the criminal justice system. When I have been attempting since he was 8 years old to get help for his mental health and just was completely unsuccessful. It was a really sick feeling in my stomach every time I had to pick up the phone and call the police again. My employment was at risk until it got to a point where I had no choice but to leave employment altogether, to stay home and try to maintain a basic level of safety in my house. The constant level of stress ended up, at the age of 46, I had a TIA, so a mini stroke. That's not normal. I'm not blaming my son for that. It's just the overall stress level that we lived with just takes its toll on everyone in the home. So again, my son did qualify for the SED waiver, the serious emotional disturbance. Services that we tried to utilize were in-home therapy, wraparound, CLS, and various others. At one point, despite trying to work with community mental health in the system, I was actually threatened with someone contacting CPS and reporting me for child abandonment when my son had been in a hospital placement, and they said, you need to take him back home. And I questioned that for the safety of the rest of the family members. They said, well, we'll call CPS and report you for child abandonment. So that is a very common theme that a lot of our families have experienced. So in conclusion, raising a child with severe mental and behavioral health challenges is beyond difficult in itself. Having little support, ineffective or no services, and trying to learn to navigate the systems while in the middle of crisis adds exponentially to the burden. Legally, our children and families are entitled to this care. Unfortunately, we have been denied, given misinformation about services, and even flat out lied to, with nearly every effort that we've made to try to get services for our son. So my son is now in the juvenile justice system. He's not a criminal. He is a youth with severe mental and behavioral health challenges. But the current system left me no option but to pursue police involvement, which results in my son now having a criminal record. Michigan needs to rebuild the mental health support system that's been dismantled over the last number of years. Funding absolutely must be provided for oversight and accountability to ensure that CMHs are providing supports and services in fidelity to the models that they profess to follow. Michigan needs to provide facilities with appropriately trained staff that offer both short and long-term residential placements. I'm not talking institutionalization. I'm talking get your children the help they need and let them come back home. I have been accused so many times of just wanting to get rid of my son. I have fought for him since the moment I met him. The last thing I want is my son away from me. But right now, he's in Cheyenne, Wyoming through a court placement because I couldn't get mental health help through Community Mental Health Organization in Kent County. We want effective treatments so that our children can return to our homes and have the hope of a meaningful future. Thank you for your time.
Thank you for your testimony. I just have a quick follow-up. So what do you think is really specifically missing? Is it long-term residential care and then wraparound? Like, what is it do you think would actually help children with SED? I know it's not an easy question, But what specifically could we do?
Well, everything is underfunded, obviously, so
I don't think your mic is on.
it's red. Now? Yeah. Maybe I need to move it. Is that better? Thank you. I'll get closer. So everything is underfunded right now, and so the CMHs are playing this dance of providing the very minimum that they can get away with to move children through the system. And so you see that there's not proper pay for the staff, which means that they never have staff, which means they're constantly trying to cut your services. So if CMH was properly funded and properly overseen, those services would be very beneficial if they worked properly. We've talked to a few people who have received them in fidelity to the model, and it worked great for them. So that's one thing. And also, yes, we need the residential treatment centers that are beyond inpatient stabilization, but provide a longer-term treatment model so that we're not just stabilizing and then sending home. And then, of course, the oversight and accountability to make sure that that these places are providing the services properly.
Okay, thank you both for being with us this morning.
Thank you.
Thank you.
Next, we have Molly Dixon on Zoom.
Hi,
Molly,
my
you
name
can.
is Molly. I live in Kent County, and my son has been on the SCD waiver for over 4 years, I guess. To the Honorable Christine Morris, the chair, MDHHS Appropriations Subcommittee, and members of the subcommittee, thank you for hearing our stories. I was one of the parents who spoke at this hearing last year. I have a son who's 12 years old with extreme emotional impairment and mental health disabilities like fetal alcohol syndrome, reactive attachment disorder, autism spectrum disorder, borderline intellect, and pediatric bipolar. He has been in continual home-based and occasionally community-based services for the past 8 years. But as he's gotten older, his behaviors have become more extreme to include homicidal and suicidal behaviors, sexual assault, elopement, property destruction, and domestic violence. 3 years ago, we spent a year cycling him through the ER system, and we were routinely denied beds at psychiatric hospitals due to lack of availability or due to him not meeting the criteria on that particular day. He eventually got on probation because we needed to start calling the police due to the severity of his behaviors and the inability of CMH services to be able to come to the house and then quickly to deal with the crisis. During that time, during the last few years, he spent a couple of short times at Pine Rest. He was also at Harbor Oaks and Hawthorne, both which were very short stays. After repeatedly violating his probation, he was placed in the detention center in January of 2022. The goal has been and still is to find a residential placement for him. He remains in detention to this day because there have been no placements found that will accept him or that our CMH or the judicial system will send him to. We go to court in 2 weeks where he will be declared incompetent and will need to be released from the detention center. We have been counseled from his lawyer, probation officers, and some members of our CMH to give up our parental rights because that will open up placement options for him. We have been told that if we do not bring him home, we will be charged with neglect. Our judge is discussing the option of removing him from our custody and placing him as a permanent ward of the state. Both of those options are immoral, but also place my husband and I in the position of being opened up to CPS, being charged with neglect, risking the custody of our other children, and being put on the registry. If we choose to bring him home, he will be placed back on the SCD waiver with possible ABA services, but we are also facing the possibility of CPS wanting to remove him due to the violence of the other children. We have exhausted every resource available to get him help and to keep our family safe, and we want him to come home, but he is not safe, and we are not safe with him there. Because there are no residential placement options in the state of Michigan for children with Medicaid, we have looked out of state and have been denied everywhere. My son, who is 12 years old but has the emotional and intellectual ability of a 7-year-old, has been criminalized for his mental health, and that is a shameful reflection on our current system. He has spent longer in jail than all of his mental health placements combined. I would ask that the committee recognize the crisis that parents face every day with our children that have severe mental health disabilities and will put into action a plan to help those with residential support, more holistic and available CMH services, better access to psychiatric services, and a stronger effort to prevent children from being placed in the juvenile justice system due to lack of facilities, staffing, funding, or staff education. Above all, we need to believe that this is a crisis, is real, and to see actions towards meeting those needs. Thank you for your time and consideration.
Thank you, Molly, for your testimony today. Next, we have Kevin Frame on Zoom. Okay, we can come back to Kevin if we know he's back on with us. Alethea Mashar.
Hello, my name is Alethea Mashar. I live in Montmorency County. My 17-year-old son is on the children's waiver. The Honorable Christine Morse, Chair of the Appropriations Committee, and members of the subcommittee. 6 years ago, when our son was selected to receive the children's waiver, we believed we would finally get the help he needed after years of living with severe behaviors. His first behaviors started at the age of 3, around the time he started treatment for leukemia. In the time since he's been on the children's waiver, we've accessed community mental health crisis services on numerous occasions, gone to the emergency department as directed in this community mental health crisis plan, had the police called to our home, both by us and by CMH crisis staff, who was terrified by my son's behavior and completely unable to de-escalate him. He's also injured himself, me, and my husband, including broken bones and causing post-surgical complications that have required another surgery for my husband. He's damaged much of our property. His diagnoses are Down syndrome, autism, ADHD, schizoaffective disorder, bipolar type. His intellectual disability is severe. His behavior is severe. His medical needs are complex. My parents, on multiple occasions, have strongly suggested that we relinquish our parental rights because it's the only way they can see that we can get our child the help he needs. In our family, 2 emergency room doctors and a psychiatrist have recommended that we take our child to a large children's hospital emergency room, preferably University of Michigan, and leave him there at the hospital so that they would be obligated to give him the care he needs in our absence. That is seen by our family as the only way to get our child the help he needs. He's been in the University of Michigan Child and Adolescent Psych subunit, a 3-bed subunit. That's the only hospital in the state that can care for him. Right now, their wait list for him to get back in there is well over 6 months. And he's having severe behaviors, delusions, hallucinations on a daily basis. Our community mental health clinical leadership team recently denied our son a referral to DART, which is a program that has an on-site autism care program. A referral that was recommended by the University of Michigan psychiatry team and by their own psychologist. They denied it because he hasn't had enough failed hospitalizations, even though there's only 3 beds in the state that can manage his care. Meanwhile, my husband and myself are managing his care by ourselves daily. He requires hands-on support with all of his activities of daily living, including intermittent catheters for urine, briefs for bowel incontinence, a daily bowel cleanse, and all of his hygiene needs. He often refuses that care, leaving him not hygienic as he should be. We've exhausted all of the options that we have for therapies. We have one person who is able to work with him, a 60-year-old woman who plans to retire later this year. My request is that you allocate resources to keep our child safe at home, or allocate resources for a safe place for him, a structured, safe environment before he reaches adulthood in less than a year. We waited 14 years for real help that we thought was coming 6 years ago when he received the children's waiver. It is not there. There is no programming for children with severe intellectual disability and severe behaviors.
Thank you, Alethea. Thank you for sharing your life experience. Next, we have Denise Fromm.
Hi, my name is Kevin Fromm. Our Zoom is under my wife's name, Denise, and I will be reading a statement today on behalf of a parent who is unable to attend this session. My name is Heather Fraser Isifan, former Captini, unable to be here today because I'm a nurse and I need to work. My younger son is suffering. He is also experiencing depression, and this is happening because his severely mentally ill older brother is not receiving the mental health treatment. His family is continually traumatized in our home. His older brother does not get the care he needs, and I have exhausted all resources per community mental health, CPS, and the court system. We currently live in Shiawassee County, and the former sheriff, Mr. Beagle, is also our state representative. He may recognize my son's last name, as the police, sheriff, and state police have all responded to calls for my eldest son's mental health crises multiple of times since we have become residents of the county. At this time, when we call 911 for help to keep us safe, Central Dispatch notifies both the local police and the 2 state troopers to respond to the severity of our eldest son's mental issues and his resulting actions. My eldest son has been in the care of community mental health at Shiawassee Health and Wellness, as well as Genesee Health Services, and private psychiatrists and therapists since the age of 3. That is almost 12 years. He has multiple diagnoses: autism, DMDD, which is dysregulation disorder or disruptive mood dysregulation disorder, major depressive disorder, anxiety, suicidal ideation, and psychosis at times, and he was most recently given the diagnosis of conductive disorder, a severe mental condition that all people with antisocial personality disorder have as children. We colloquially know antisocial personality disorder as sociopathy. To give you an idea of what that means, my son has been in intensive care for cognitive behavioral therapy most of his life. He has done ABA, the gold standard therapy for autism, twice with no results, and we are about to start a 3rd time. He does have a RAP team and is in special education for emotional impairment. He has been on dozens of medications for his mental health disorders, big antipsychotics, and continues to be on them now. Abilify, Respiridol, Haldol, Zyprexa, Triliptol, Depakote, just to name a few. While we have continually sought intensive therapy and the right medication for years, he is still uncontrollable. I have begged for residential care because he is dangerous. I have been continually denied. We are refused the intensive residential placement his psychiatrist has requested since June of 2020. In that time, he has masked multiple assault charges. The police have responded for hitting a teacher in the head with a rock, causing great bodily harm, for assaulting people with deadly weapons, for attacking police officers, for attempting to get police officers guns twice, for physically assaulting me, and I have 3 herniated discs in my neck from one assault, for assaulting his stepdad, assaulting his biological dad, assaulting his grandfather, assaulting his brother, assaulting other children in the community, and assaulting other teachers. I have pictures of the results of the assaults, punches, kicks, digs, bites, and strangulation marks, should anyone want to see them. In that time, community mental health points its finger at the justice system, and the justice system finds him incompetent to face his charges and points the finger back at community mental health. No one will help him, so the entire community continues to suffer. My eldest son is released back to me immediately after arrest and refusal of placement, and I am told to do my best to keep him safe. When the justice system did his competency evaluation for his first felony assault, they found in 1 year that he had been to the ER 19 times for placement, many of those times escorted by the police, and no one was willing to accept him, even in crisis or short-term inpatient, because of his violence that required physical and chemical restraint at the hospital. He has been to the ER with police escorts dozens of times. We are begging for help before my son, who has exhausted all resources according to medical professionals and the justice system, costs someone their life. Each time he is arrested, we go to the hospital just to be released back into the public because no one will help us. Per Judge Godola in Genesee County Court, January of this year, 2023, she said, "Mother, I would just continue to encourage you to pursue services." Mrs. Bates' input, Mrs. Bates is the juvenile delinquency caseworker in Genesee County, is that you have done everything you can, probably above and beyond, to try to help your son. Just please keep doing that. Since that court date in January, he has assaulted me, my husband, a Durand police officer, bad enough to injure him and cause destruction to police property in one incident as well, and attempted to take control of a vehicle to kill me and my younger son, in which it took 5 officers to catch him and get him under control. So here I am with other parents struggling, publicly addressing this issue with people with the most power in the state. Please help us, since community mental health will not. Please help us keep my son from harming others, harming someone else again, or worse yet, our police department being scrutinized in the court of public opinion for doing what they very well may have to do someday in order to keep the community safe, since the mental health services we pay for both publicly and privately are obstinately choosing not to do their job. Please choose today to save not only my son's life, but our community and our officers. There is only one way this will end without placement for my eldest son. Thank you for taking time to listen.
Thank you for providing that testimony. Next, we have Megan Gunnarsson.
Oh, thank you. My name is Megan Gunnarsson. I am a resident of Washtenaw County and the mother of 4. I initially came on to read the story from another parent who was unable to participate today due to working, but also wanted to share my story. I have a child who had 14 admissions in 14 months for severe suicidal ideation and attempt. Each time she was released back to the community too soon. Of those 14 hospitalizations, 3 of them were placed out of state in short-term residential care. Each time she was released prior to completing the program due to insurance. We were placed on the CMH waiver during her last admission because her community-based psychiatrist and her community-based psychologist both dropped her from their practice because her medical liability was too high. We were promised wraparound services and family support, neither of which were obtained due to short staffing issues. Our child currently is out of the hospital, but not well. We have not been part of the juvenile justice system, thankfully, but I don't rule it out given the stories that I hear in the community and the suggestions that have been given to us by medical staff. We have brought her home at times, I'm sorry, because it was either bring her home or they would release her to a homeless shelter. Our other children have been very damaged by this merry-go-round system. And I ask you to please better fund community health as well as hold the insurance companies responsible for releasing children prior to wellness due to dollar signs. And then the statement I wanted to read is from an Otsego mother who is at work. You may understand that a lot of us use our vacation time and our sick days in the ER with our children. This mom is currently at work without vacation time. My 13-year-old daughter has been in and out of short-term hospitals or placements 3 times since October of 2022. She's been diagnosed with ADHD, DMDD, PTSD, anxiety, and depression. She also has developmental delays. All of this is causing her to become suicidal and homicidal. The last time she was in hospital earlier this year, even CPS said she wasn't ready to be discharged, but Havenwick discharged her anyway. I was afraid to bring her home, but I had no choice. I left the hospital with her and CPS helped me drive her home. We were only 5 miles down the road when she started saying she wanted me dead and wanted to kill me. She got so physically aggressive that the CPS worker had to stop her from choking me. Police were called and she was taken back to the hospital via the police to be pre-screened and re-screened for mental health services. She hit, shoved, and pinched me every day in the emergency room while we were there waiting for an inpatient bed. She cussed me out, telling me again how she wanted to kill me. This went on for 2 weeks. I was advised by community mental health and CPS not to be at the hospital with her. I left and have been told for my safety not to return until we get her placed into a facility. CPS has been involved because she keeps making false accusations against us that cannot be substantiated through CPS investigations. She has now been in the ER for over 2 months waiting for a bed at Hawthorne. We were told over a month ago that she would get the next female bed at Hawthorne. She is giving up hope that they will place her. We talk on the phone. Sometimes the calls are good and other times not so much. But it's hard to keep telling her that it'll happen when it's taking so long. The ER room itself is a jail. Can you please help me make sure that she gets an immediate placement at Hawthorne? We love our child and we only want her to get the treatment that she needs so she can come home. Her mental health needs to be addressed and I fear that we are losing time and her condition will only worsen the longer that she waits. Thank you.
Thank you for your testimony today. Frank Van Gotham, if you're with us on Zoom. Frank Van Gotham. It's your time if you're here. Okay, moving on to Doug or Carlotta Wolf on Zoom. Doug or Carlotta Wolf.
Okay, we'll check back with them. Finally, we have Heather Bither.
And the 16-year-old is the one at risk, thankfully. The biggest guy at the house.
Heather, or have you joined us on Zoom?
Vulnerable people in our house. So just making sure that we have.
Sorry, Heather.
The things that we can do.
Heather Bither, if you're with us on Zoom, we can't see your video, which is okay, but you've also been breaking up. Oh, it sounds like she's on the phone. Yeah, I think that's what's happening. I'm sorry. Oh, no, thank you for letting us know. Okay, then we're going to move on to Stacy Ganson.
Can you hear me okay?
Yes, Stacy, go ahead.
Good morning, I'm Stacy Jensen. I'm representing my son today. His name is Brennan Jensen. I'm also a member of the Advocates for Michigan Youth. What I'd like you to know about my child is that he will absolutely either kill himself or somebody else someday. Absolutely. There's not a doubt in my mind. I've known him his entire life. He's been different from day one. He currently holds a diagnosis of a potential thought disorder. It just depends on which side. As he's only 16. However, he does have auditory and visual hallucinations daily, as well as homicidal and suicidal ideations. He has been violent against himself, his caregivers, in school, you name it. We do have a SED waiver. We currently receive psychiatric services through CMH, in-home therapy services through CMH, and wraparound services through CMH. And he is currently at his second hospitalization at Hawthorne Center. In the last 3 years, we have also been to White Pines, Pine Rest, and Mott Children's Psychiatric Facility. What I would like you to know about the current Michigan mental health system is that it is a fast track to jail simply for lack of training and education. I didn't even know about the SED waiver until I joined the Facebook group. I have experienced several subpar medical providers. Our psychiatrist at CMH was happy to comply in continuing to prescribe a stimulant that Hawthorne Center put my psychotic child on. Anybody can use Google and see that that's a bad idea. At Hawthorne Center specifically, my son personally has been physically, verbally, and sexually abused. I have proof, written documentation from Hawthorne of the sexual and physical assault, and I'm awaiting an investigation through recipient rights on the verbal assault. None of these facilities are up to par. And the other thing I need you to know is that Hawthorne Center is the only facility in this state that is able to care for my child due to his acuity level. And I don't have the resources to put myself in debt and take him into another state. I am unfortunate to be a citizen of the state of Michigan. And my child or somebody else's will pay for it until we start educating and enhancing these staff members. Every time I call that facility, it's they're short-staffed, they're doing their best. This is nobody's best. I do their job. I'm a CNA at an adult psychiatric facility. I have never physically, sexually, or verbally assaulted a patient. There's no reason for it. I have never discharged a patient without them being ready to go home. That's the problem I faced at Mott Children's Psychiatric Facility. The lead psychiatrist discharged my child while he was delusional. With his CMH team behind my back, I had to refuse to pick him up, for which I was penalized with a CPS investigation for medical abandonment. However, it had already been pointed out to me by his therapist that if I brought him home, they would be reporting me to CPS for endangering my 4 other children, 2 of which are starting to show signs of mental health issues for having trauma of being exposed to their brother, who's been seeking mental health services in the state of Michigan since he was 6 years old. That's 10 years now, always in Livingston County, always were getting nowhere. He's still just as unwell as he was on day one. He's seen specialists at U of M. He's seen specialists at every facility. This is inadequate. This is inadequate. And aside from the staff having poor training, they don't listen to us. I cannot tell you how many times I have told a facility, my son is not ready to come home. He is still delusional. I can tell you he's not ready. And they either end up back in a facility within a day, it could be a week. I get disrespected and told that I just don't want my child to come home. I actually had the director of the University of Michigan Psychiatric Facility tell me that my opinion about my child's mental health would hold weight when I graduated medical school. Bizarre. This is unreal. And I got put in a position where I was going to face a CPS case no matter what I did, trying to keep my family safe. It's unfair. And there's nobody to help me navigate this system. I do have a representative with the wraparound system, one for my son and one for me. I've spoken to my personal maybe 3 times in the entirety of our services. She's offered nothing. I have nothing. The best place that I can go for help in navigating the system is my secret Facebook group. And that's pathetic. That's really super sad. I want to thank everybody for your time. And if you have any further questions about things that can be done for training, for staff, any kind of remediation, please feel free to reach out. And just the last thing I'd like to highlight for you guys is that Hawthorne Center in Northville is a cesspool for neglect and abuse. And the reason our children are in a turnaround system there is because it's the farthest thing from a therapeutic environment that you can get.
Thank you, Stacy, for your testimony today. We're going to go back to Heather, who is on the phone. Heather, go ahead.
Like that. Moving forward, it will not be like that.
Heather?
So we'll sit down Tuesday and talk about that and services that you're looking for and how we can help you.
Heather, I don't know if you can hear me, but I'm going to request that you maybe email us with your written testimony because we're really having trouble hearing you. But we would like to hear what you have to say. So I'm just going to suggest that you do that. Next, we have Terry High.
Hello, I'm Terry High from Taylor, Michigan, Wayne County. Thank you for hearing from me. I am a disabled Army veteran and father of Chelsea Ray and founder of the Chelsea Project, and we're working towards nonprofit status for Wayne County to help with these mental health issues. My daughter is a 26-year-old certified medical assistant and mother of 3, ages 3, 4, and 7. On August 20th of 2022, she was hospitalized for the onset of severe psychosis while trying to buy a house with her fiance. Since then, she's been bounced between 5 short-term facilities and is currently hospitalized at Stonecrest. She's been discharged 4 times unstable because the insurance companies have pushed for her discharge. Every time she's been discharged to my home instead of back with her family. I've had to put in safeguards to protect myself, my girlfriend, my daughter, and my neighborhood. In addition to the security system I already had installed, I put in double-cylinder deadbolts on all the entry doors, locking doorknobs on my bedroom and laundry room, locks on the refrigerators, cabinets, and drawers, installed camera systems, locked up my carry weapon. I carry pepper spray and handcuffs, and I'm taking a taser course because it takes up to 5 people to restrain her during an episode. No parent should ever think about having to do this to their child. I feel like a prison guard in my own home. And with my PTSD, I feel locked in and actually over-secure. We've been fighting for long-term mental health for her, and there are no rehabilitation facilities. So we've had to look at placing her in adult foster care as the safest option. Medicare doesn't cover this, so we have to apply for Social Security. Even with being in an adult foster care, she's still not going to receive the treatment that she needs. This is basically, as far as I'm concerned, an incarceration of my daughter. And this is unconstitutional. We need the mental health services to get these people the help they need to become productive members of society again. Please put the money back into our mental health care system and bring back these long-term mental rehabilitation facilities. Thank you.
Thank you, Terry. And we have Jessica Nietro.
Hello, thank you for letting me speak. My father, Brian Terrence, with me here today as well. I have 4 children, and they all come to me through foster care. So we're talking kids with probably the most mental health issues in the country. My 4 kids, they have an extremely bad background. They entered foster care. My youngest was 8 months. She's now 5 years old. Then they were 3, 4, and 7. They stayed in foster care for about 3 years until they came into my home. 3 of the 4 now have permanency. We have legal guardianship of my oldest, and my 2 youngest are adopted. They have a 3rd sibling, and upon entering foster care, this child was immediately removed from her siblings at 4 years old. 4 years old, they just deemed her unsafe already to be with her siblings. From there, she bounced around through foster homes until she was 7, and she was placed in a group home. Thankfully, she was stabilized in this group home, and when we met her last year at 8 years old, she was doing really well. She is mentally probably closer to 4. She likes to play with her play kitchen, and she laughs, and she plays with my kindergartner and my preschoolers more than she plays with older kids. Well, she was stable. She entered our home last year once she was deemed stable, and things were going great. She went from a kindergarten reading level to reading most of her 2nd grade sight words. And then at 9, she started her cycle. And with kids on medication, this often changes their hormones. So her meds that once stabilized her and made this happy-go-lucky girl were no longer working. We started having extreme violence. I mean, she kicked down her door and then tore it into pieces, throwing them at us. She's 9 years old, but she is 5'5" and 140 pounds, so it's dangerous when she gets violent. She's given me 2 concussions. She's bitten my husband to the point where he has he was bleeding. She's torn all of her toys into pieces. She's had the cops come to the school and sent 4 teachers to urgent care because she was so violent. So we're talking about a kid who can be stable on medication, and it's been proven, but she needed new meds. We went to the crisis center 6 or 7 times and were denied treatment and further treatment from her each time, and they said that they couldn't help. We had the cops called, they couldn't help. The only people who actually listened to us was the CPS, who came out to investigate us for abuse, even though we were screaming, our child needs help. What she needed was a med wash so she could get on new meds, but there's no resources in Michigan for somebody to institutionalize her in a therapeutic setting for a med wash. There was no one to help her. We're talking about a 9-year-old who likes to play with her play kitchen, who just wants help. She was sitting there telling the screening that she hears voices in her head telling her to hurt people, and she wants new meds so she can feel better and play nicely with her siblings, and they just sent us home with her. We spent weeks in the hospital rooms, and during this time, they didn't even give her normal meds on time. We had to find nurses, follow them down, and ask them for her meds, and they still wouldn't give her meds on time, so she just got more destable and more destable. Last week, she went back into the foster care system because it was deemed we couldn't keep her other siblings safe with her in our home. So instead of being with her siblings, like she should be as a 9-year-old kid, she is back in California because she was a dependent of California, sitting in a room waiting for somebody to let her in a bed to get the treatment she needs. A 9-year-old away from her siblings. I have my 11-year-old who's self-harming because she misses her sister and wants her back, and a 7 and a 5-year-old who are crying every night asking when their sister can come home, but also if she'll be safe and she won't hurt them when she comes home, right? And I have nothing to tell them because there's no resources for her to get help in Michigan. So I don't think she can ever come home unless we move to a different state, because the resources are so bad here that a 9-year-old can't get stabilized. I'm just asking that funding goes into institutions that we need real residential institutions. 5 to 7 days isn't going to stabilize any child, and that's where most of our inpatients are. And usually a lot of kids, like you hear, spend months in the hospital not getting the appropriate meds for that 5 to 7 days. That does nothing. We need 3 to 6 months institutions where these kids can get EMDR therapy, trauma therapy, group therapy, and a stable environment where it's safe. We need psychiatrists who will prescribe the right meds, because most of these kids can be stabilized on medication, but it is a pain finding the right meds, and it's months of work, and they need some place safe to go for this to happen, so they can come home to their families, because it is possible to bring these kids home and safely. We just need the right resources in place, and Michigan does not have these resources. So I ask that funding goes to CMH and other facilities that can provide these kids with real hope for the future.
Thank you for sharing your story.
I don't know, am I on?
And use that one.
Oh, try that. So, I won't repeat her story, but we've done this for generations now as a family, so it's to be hard speaking after listening to her pain. But I want to talk about my youngest adopted daughter. She's just about 18 and no longer living with us. And we essentially had to make the decision to just let her live on the street because there was no help from the system whatsoever. She assaulted me twice. She pulled a knife on me once. We spent time in ER. We spent time at community mental health. And the police finally told me that my best thing to do was to quit bringing her home because there was simply no system in place to help her. So she spent the next year and a half. She's finally stabilized somewhat by self-medicating on marijuana, and she's living with a biological sister. That's not the best of environments. It's the best environment she's been in the last year and a half. She spent a year and a half just about living on the streets, staying with random people. And it's because our system had nothing in place to help her. There was nothing we could do as parents. There was nothing the school could do. There was nothing the police could do. We even looked at the possibility of charging her. And the police essentially looked at me and said that their prosecutor wouldn't even take the case, even though she had pulled a knife on me and she had punched me to the point of causing blood. And it wasn't that I wanted her in the criminal justice system, because I wanted somebody to help us, somebody to help her. And there's simply nothing. And I look at it again with my grandchildren, and I think, shame on you, shame on the government, shame on the state that has taken a system. And before your time, I get it, but it's taken a system and gutted a mental health system in the state and is not doing what needs to be done to fix it. We want to look at the bigger picture. You know, the gentleman read a statement before us on here about, you know, a couple of parents have said their children are going to harm people. We look at a system where we continue to have mass shootings, we continue to have assaults throughout, and the thing that I hear the most when you go back and you read those stories is those parents of those young people had begged for help. They had sat in the positions like we're sitting in now, and they had begged for help, and the system has failed them. So I'm asking you, I don't know the system, I don't know the bill names, I don't know which sources you got to put, what sources you need to put money into, but you're elected to office to try to find a way to put the money in the right places to do those things, because we're going to continue to have these problems. And the micro level, right, is look and see the heartbreak that happens in individual families. At the larger level is to see the heartbreak that continues to happen because we don't do anything about it, and we turn it into a macro level. So I just implore you, as you're looking at your finances, and you're looking at this appropriations bill, that you put the proper money in the places that need to be in order to prevent these tragedies in the future. Thank you.
Thank you both for sharing your stories and being with us today. Okay. Next, Ron Slagle and Jason McDonald.
Good morning. My name is Jason McDonald. I'm with MedStar Ambulance. We are a large nonprofit ambulance service serving Southeast Michigan, Genesee, Bay, and Central Michigan as well. Excuse me. I'm also the president of the Michigan Association of Ambulance Services. we advocate for the EMS in the state of Michigan. With me today, we have Ron Slagle, who is our reimbursement committee chair. He'll read a statement, introduce himself, and then we'd be happy to take questions on reimbursement.
Good morning. My name is Ron Slagle. I'm the president and CEO of Emergent Health Partners. We operate 4 not-for-profit ambulance services in the state of Michigan: Huron Valley Ambulance, which covers Washington, Wayne, and Oakland counties; Jackson and Monroe Community Ambulance; and Life Care Ambulance serving Kalamazoo, Calhoun Branch, and St. Joseph counties. After decades of underfunding, Michigan EMS providers received nearly $13 million in additional funding for EMS reimbursement in the fiscal 2021 budget. Before this investment by the state of Michigan, our reimbursement rate had not been increased for over 20 years. For reference, Medicaid only pays about 35% of what commercial insurance pays for ambulance services. We were truly appreciative for this increase, which made a significant difference for EMS providers and was used to increase wages for our dedicated EMTs and paramedics, but it fell short of the intended result and due to ambiguity in the boilerplate language, resulting in payments below the intended allocation. The legislative intent was for the Medicaid allowable reimbursement rates for EMS treatment to be equal to the Medicare allowable rates. For the funding increase to be allocated as legislatively intended, all advanced life support and basic life support lines need to be increased to achieve parity with each Medicare rate. Only allocating the increase to the Medicare base rate did not properly increase the reimbursement for the level of work being done in EMS. The problem is more technical in nature, and we can answer any questions about the specifics if committee members wish, but to make sure the funding is properly allocated, the boilerplate language must be changed in this year's budget so that all ambulance services lines are paid at not less than 100% of the Medicare allowable, so there it is not ambiguity or misinterpretation of the intent. Thank you for your time today and your attention to this matter. We would be happy to answer any questions if you have any.
What, do you have an estimate for what that is on a yearly basis? What increase in funding you're looking at on a yearly basis?
So we have worked with House Fiscal and the department on that. So I don't have that information there, but if we have this legislation boilerplate available, then I know they would be able to work through that, but I don't have that information.
Okay. Any other questions? Thank you, gentlemen, for being with us today.
Thank you.
Thank you.
Next, I'll call up Siobhan McGowan.
Okay. Good morning, Madam Chair and the committee. My name is Siobhan McGowan. I've been an educator for over 20 plus years. I've been a teacher, principal, but now I'm the director and owner of Seeds of Knowledge Creative Learning Center in Detroit. The vision and mission of my program is to provide a nurturing academic and a socio-emotional rich environment to ensure that our little ones don't have any foundational gaps when they matriculate on to K-12. I'm here today after reviewing the proposed executive budget, and I'm concerned and fearful of the viability of my small business along with the other small businesses in my community that service early childhood. We feel a need to be to address so that we can ensure high standards in our industry. But before moving forward, I want to mention that I did write a proposal for enrollment versus attendance for subsidy payments, which was adopted in this budget, which is helpful, but it's just not enough. Two major concerns that we have is quality and equity. And quality, which means meeting or exceeding customer expectations, and then equity, being fair and impartial. And looking over the budget, it just isn't equitable for all of us in business owners and entities that service early childhood. The rate of pay isn't equitable, nor is the assessment of quality. So unfortunately, the same proposal that I wrote that for attendance versus enrollment that was adopted pays me $2 to $5 less than because I don't participate in the rating program that would determine my quality as a business owner. The tiers reflect subjective variances of quality for the rating system. Based on what the definition of quality is, I am a high-quality learning center. I train my team. I have all the responsibilities of any business. I follow the Michigan Child Licensing Handbook, but I am penalized financially for not participating, which is not equitable. It's just not. It's like $4 an hour if I don't participate versus somebody else will get, right now it's like up to like $9 or $10, but it's a difference. We're a brand. I have my own business. I provide the quality. I'm educated, and someone down the street can get more because they participate. It's just not equitable. We do the same things. We're a business. We have the same standards. The licensing, everything is the same. So I'm advocating today for maybe it's a specific budget similar to K-12, which I'm used to participating in, that they can review for early childhood businesses that we can pull in so that we could be comparable. So that, like right now, I had a teacher that was with me for a year and a half, $15 an hour, which exceeds my budget, but as soon as she got her certification, her CDA certificate, she just left me inside of 3 weeks to go somewhere else to make $18 an hour. So now I'm short because I can't compete. We need quality to be absorbed in our licensing. The manual is there. It's all wrapped up inside of that. So these extra tiers and stars and levels and things, it should be absorbed in our initial licensing. We're the only industry where it's not, where I see that it's not. I'm advocating that we receive the same coupon vouchers for background checks, not just Head Start. That's what it says in the budget. We do background checks as well. So why is it isolated? It's not equitable for Head Start to just be able to get licensing and vouchers versus, all of us in the same industry. To remove barriers for accessing childcare, we have a stipulation that in order for moms to be able to receive support, subsidy for their childcare, that they have to go through child support, and there's not always fathers viable in the home for that. So that's a barrier. I'm also advocating that the current budget be reviewed and just realigned to be inclusive of all early child care businesses. There's K-12 provides per pupil funding based on, of course, you all know the property taxes and things like that. Medicare and Medicaid, those businesses provide services. They get the same pay. It's not different. If you go to one dentist, you get your teeth cleaned, it's the same fare. It doesn't matter what your dentist office looks like. It's all, it's all there. We need to transition to an equitable measure of standards. Quality is subjective, not quantifiable. We all have our own brand, our own creativity, and we should be recognized as such. The last thing that I wanted to say was the quality care just really isn't reflected in the budget, the standard of high standard care for our children. And after hearing everyone speak today, like it starts somewhere, and we need to be able to, work together so that our children, which from the little ones that we get, even the parents that we're just talking today, we just not serving our children well. We need the same rates, equitable rates for the services that we provide, and as business owners, it's just imperative for us to be able to do that under the system that they have now. It's not designed to maximize the quality, it's designed to minimize the cost, and that's just not fair for our children. So, thank you.
Thank you, Siobhan. I'm just going to note, we have a number of cards, I think, on in a similar vein. We'll call y'all up, but just so you know, that's not really technically part of this budget, but you can feel free to come up and share your thoughts today. So next we have Tony Adams of Creative Academics. Tony, are you here?
Hello, as she stated, my name is Tony Adams, and I'm the owner of Creative Academics Learning Center in Detroit. Basically, I'm here. I guess I misunderstood because you just said that this wasn't for.
I'm sorry, I didn't explain it well enough. So you're here today for the Health and Human Services budget, and childcare is not
under this budget, unless it's part of the child welfare system. But otherwise, I think the childcare you're talking about is more under the education budget. But you're here today, so you can take your time and go ahead and share your thoughts.
Okay, well, that was a misunderstanding.
Yeah.
We're at the wrong meeting.
It's okay,
But I have
yeah.
the same concern as the other child care provider with the proposed legislator that's coming out with the GSRP, where they're focusing more on the GSRP and the K-12. They're taking away from the small business owners in the child care industry. We're not being they're not reviewing exactly what's taking place in the neighborhoods. They're just focusing on the elementary schools and suggesting that the early childhood be a part of the K-12, which is harming the small business childcare owners, and it's taken away from us to be able to compete with the Detroit public school system. And that's it. So can you tell me when that meeting would be?
I'm not sure if and when education will be doing a public meeting, but I can ask my colleague, Rep. Weiss, and see if that will be available. But you're all welcome to come up. I mean, many of you came from, you drove for a while, so we're happy to have you have a forum. You can go ahead and keep.
Thank you.
If you're interested in sharing your thoughts, come on up.
I'm going to pass out our rate of pay. And so I'm not going to be on Michigan Department of Education because I know that's that budget. And I want to just talk about the DHHS. Is that we at the right place?
Yes.
Okay, great. And so my name is Nina Hodge, and I'm the director, owner of Above and Beyond Learning Child Care Center. I worked for Chrysler for over 23 years, owned the daycare for 25 years. I started this business because I knew it was a need in my community and at the manufacturer level. The budget that the governor is proposing in front of us that they shared with us is not equitable for us at all because there's so many barriers for us. Based on the cost of living that has went up, while our pay has been decreased, that you have the paperwork that's in front of you. So I'm very grateful that the governor gave us that. However, nevertheless, April the 9th, our wages is going to be decreased. For me, I am a 4-star down to $6.90. We cannot run our business off of $6.90 when I have my employees right here, when I gave them not just 10-cent raises, $1 raises, $2 raises. So I'm asking at the same time that we need to put money into that funding. The governor also have on here about the $64.25 for our fingerprints, and that's for Head Start programs and federal programs when we need funding as well, the child care providers that's here and in the state of Michigan, because we can't afford the increase of the fingerprint. Also, we get paid by a class and a star rating system, and we're asking can that be removed because on a committee, you all get paid and you know your operational costs of what you're gonna get paid on a monthly, weekly, or annually. This budget right here that they gave us, our hourly rate, we don't even know how we're gonna make our money depending on our children that come here. But the enrollment versus attendance is great, but nevertheless, the money here has been decreased. Knowing eggs, milk, and everything has went up. Without us in this industry, business cannot succeed. Business cannot succeed, and employers will not be able to retain their employees because they need child care. And we should never be an afterthought at all. So I'm also asking to, knowing that I'm starting my industry all over again based on the people that used to work for me, they no longer work for me. So I have all these beautiful women that have been with me for a whole year who wants to work in this field. And so if you know they want to work in this field, to rub these babies, to educate these babies and stuff like that, we all have to start back over again. So if you work at Chrysler, if you work at Amazon, you have to train all over again. And I have to train each and every day my new employees. So I don't need a rating system. I don't need a class system. I need support at the same time. I have 60 children, and I'm licensed for 60. Out of 60, I have 10% that does have mental illness. And my staff, I have a parent behind me who, she's 100 on the list. She's 100 on the list that needs the support that she needs for her cognitive, her therapy, all kind of different. I've lost kids who needed therapy too at the same time because I wasn't aware that the child couldn't hear. and the father got the baby and did not know that his child could not hear. So I wasn't able to get the support to be able to help my families at the same time. So I'm asking you guys, when you look at this budget, the governor made it very clear that she did not support our industry at all. So going through, still in this pandemic, my kids still come with RSV. They still have COVID because we still get tested. And nevertheless, I'm thankful for the enrollment versus attendance. But we cannot move forward that April the 9th, I'm only going to be making $6.90 when it takes 2 babies to take care of 1 staff member for that day. 2 babies. And so when you paying someone $19 an hour or you paying $20 an hour to start at Amazon, then you need to look at the livable wages that I have to pay in my community on the east side of Detroit who needs that. I'm surrounded around Dakota, Lyra. I'm surrounded around Flexgate, Chrysler, who need my services. So you cannot in front of them and say to them, we want your business here in this state when you're not helping child care. So if we want to bring new business here, think about the child care business here. Think about them. And when I have a GSRP in my building with 36 children, these women right here need to get the same pay that's on that budget for GSRP. They work hard every day for those kids. They're there and they see my vision. They've been there with me for a whole year. And so I'm asking you to put money in this budget for child care, for the DHS. I'm asking you to get rid of these barriers and this fat that they got on this budget. And what is that? The fat is United Way. Hope starts here. You're putting funding in their system when you should be putting it back into our industry. Who take care of these babies? So whether you're a mother on this panel, a grandmother, or auntie, understand that they need quality and we need to keep this economy going. And without child care, Michigan would be set back. And mental illness is real. Our kids need help and support. I have a 4-year-old. The employer called me and asked me, is she lying? The child jumps around like a frog, a snake. He doesn't have language. And I have to explain that she's telling the truth. He needs help. So we need the therapy. We need the support that she's going to put back for infants and toddlers, more money. I don't understand that, how we can live off of $6.90. And then you have an industry back here that sees the knowledge. She doesn't have the star rating system. She's not in the class system. She has higher degrees, more majority than all of us in here, and she's only making $5 an hour to take care of her community. So who knows what quality is? It doesn't matter. Because we're doing a support in our community, whether it's the restaurant, whether it's the manufacturers, which I negotiate my contracts with. So I come to you today to share with you, this is not at all supporting our industry at all. And I know to go to Michigan Department of Education because I deal with them all the time when I deal with GSRP. And they have helped us with the enrollment versus attendance. But now I'm here at your table today asking you to support my families, to support this 70-something-year-old woman that comes to work every day. And I ask her just to sit in the chair and rub those babies back for those mothers can go to work. So I'm asking each and one of y'all, pay attention to the budget because the governor did not. And she didn't look at what we're trying to do in our community. I thank you for listening to us today.
Thank you, Nina, and your staff for being here with us. Next, I have Johnny Bennett. I'm not sure if I'm pronouncing that. Providers for Change.
Situated here. Okay. Can you hear me? You have to turn on the mic. How you do
There's a little button that says MIC, and it should light up.
Can you hear me now?
There.
Okay. So my name's Johnny. I'm a child care provider with the state of Michigan. I currently do home care. I'm with the Providers for Change. And I'm only going to take up a couple of minutes. The governor wants to get 1,000 child cares in the state of Michigan, new businesses. So we have several grants that they're allowing new businesses to be able to use. However, the way the grant, what I'm here for is I would like the restructuring of the grants, okay? So we have a facility grant to help you do renovations, maybe get some different furniture and stuff for your center if you're expanding. There's a startup grant, and then there's a pre-licensure grant, okay? Now, the situation that a lot of the providers are having with this is that in order to become licensed, you must have your daycare ready to receive children and license. All your inspections done and everything like that. However, we are unable to receive the funding, like facility grant funding for renovations, unless we are totally licensed. So it's defeating the purpose. So I would like for the governor to reconsider to restructure these grants. And instead of giving us a pre-licensure grant without the license that only allow us to have a very minimum amount, that maybe give us enough funding so that we can prepare our child care centers and family homes to be licensed. You understand what I'm saying? You have any questions? Okay, so basically I would like to see the grants restructured, because right now it's like a dangling of the grants to the providers who wants to expand and be a part of the governor's goal to open up 1,000 daycares in the state of Michigan. It's almost impossible because of the funding and the money, and you heard all of my co-providers here. Yeah.
Yeah, I understand what you're saying. You need to do renovations to make sure your property's ready to go, but you have to be licensed before you can do the
Right,
renovations.
and so we can't get the funding. So the funding was to help us out.
Okay, we get it. We'll pass that on. Yeah,
Okay.
all right, thank you. Next, we have to go to Bob Stein, Todd Culver, and Jan Lampman.
Madam Chair and members of the committee, thank you for the opportunity to testify this morning. I'm Bob Stein, General Counsel with Michigan Assisted Living Association, and I'm joined by Todd Culver, who's the President and CEO of Encompass Michigan, and Jan Lampman, who is a family member and an advocate. And we're here to talk about the workforce crisis in the behavioral health system. And we've heard a lot of testimony about a lot of compelling need in the system, and we think it's equally compelling for us to have a sustainable workforce to support individuals with disabilities in the behavioral health or community mental health system. We've included 3 handouts. One is a 1-page position statement from our Direct Care Worker Wage Coalition, which is comprised of a number of statewide organizations, including our organizations here today, that are representing individuals with disabilities as well as providers of supports and services. We've included a workforce survey report, which Encompass Michigan and Michigan Assisted Living Association recently concluded, and we'll provide the key findings to that report. And then finally, we've included what we think is a quite compelling story about ALE, which Jan will talk about, and the lengthy time in which he languished in a hospital because there were not direct support staff available to provide him services. We appreciate the legislature's support for the $2.35 per hour wage increase that's currently in the department budget. We also appreciate the governor's support for an additional $1.50 per hour in the budget for the next fiscal year, but we are also here saying it's not enough, that we have a real crisis, and our recommendation is a $4 per hour wage increase for direct care workers, direct support staff, supporting individuals with disabilities and families in the behavioral health system. And part of why we think it's urgent that we have that wage increase is reflected in our recent findings about the workforce crisis, which Todd will share with you.
Thank you, Bob, Madam Chair, and members of the committee. We appreciate this opportunity. Our two associations have conducted this workforce survey for 6 consecutive years. The most recent results have been distributed. This reflects input from 60 provider organizations employing approximately 67,000 staff. Some of the key findings that you'll see in that report include an average starting wage for direct support staff of $15.20 per hour, an average annual turnover rate for direct support staff approaching 42%, current open position rate of almost 20%. Other key findings not related to the workforce include that over 1/3 of survey respondents have health or safety concerns for individuals being supported because of the shortage of staff. 1/4 of survey respondents discontinued programs within the last 6 months, and another quarter are considering doing so. Importantly, about 75% of these are due to the staffing shortages that are being experienced in the field right now. As Bob mentioned, our two associations are part of a coalition of 14 statewide organizations that are advocating for an investment in this direct care workforce. We view direct support professionals as the foundation of our behavioral health system, caring for our most vulnerable residents, including those with significant and complex needs. With low rates of pay, high turnover, open position rates, this foundation is crumbling. We're therefore seeking support for this workforce and the individuals and families that rely on them, that include investments that Bob referred to earlier, a wage increase of $4 per hour for the 50,000 direct care workers in the behavioral health system in the FY24 budget. We are also advocating that direct supervisors also receive wage increases that are commensurate to the compensation of the individuals that report to them. In many instances, these supervisors perform direct care themselves and providers are beginning to experience wage compression because of that inequity. The cost estimate for this increase from general fund dollars for FY24 would be $105.6 million. That includes a wage increase for direct supervisors, which allot for 10% of these estimations. We are also advocating for an allocation of American Rescue Plan dollars to provide retention bonuses for direct care workers and their supervisors. These one-time bonuses would incentivize both joining and remaining in the workforce and assist with recruitment and retention. The cost estimate for allocation of ARPA funds would be $188 million for Michigan's 50,000 direct care workers in the behavioral health system. We believe these investments are necessary to allow service providers to compete in their local labor market, where much less demanding jobs are available at much higher rates of pay. As Bob mentioned, we're appreciative of the governor's inclusion of an increase for Michigan direct care workers in the FY24 budget recommendations. The recommended 10% increase, or about $1.50 an hour, that was included would certainly help, but it's the assessment of the coalition our two organizations are a part of that the recommended increase would not stabilize the workforce, that the crisis would continue, so that organizations providing services would continue to experience a shortage of workers, be forced to discontinue programs providing care, and that families seeking to provide care for their loved one at home would also be unable to find the help they need, continue to be left to fend for themselves, and that ultimately hospitalizations resulting from health and safety concerns could increase. We thank you for your time, for your consideration, and the opportunity to share our perspective.
One other quick comment. We also support the $4 per hour wage increase for long-term care services workers. Our coalition, this specific coalition is with regard to the behavioral health system, but as you heard earlier testimony, it's as compelling a need in long-term care as it is in behavioral health. And Jan will now talk about her advocacy as a family member and an advocate and the personal story of Al.
Good morning. Thank you for pushing us up on the list, too, because I do have a 15-year-old that I have to get home and pick up from school, and I live in Midland, so thank you for that. So I'm Jan Lampman, and I started, I have a family member, a sister, who has a developmental disability, so I came into this world pretty early on in life. However, I've worked professionally in this system for 38 years, starting out my career as a direct support professional. I now have 3 sons. My second son is a 22-year-old young man with autism whom I adopted from the foster care system when he was a teenager. And my third son is a 15-year-old, and he just joined the family last September, also from the foster care system. Both of my younger children do have either developmental disabilities and or mental health concerns, and we're lucky. You heard a bunch of parents talk about a lack of access. I'm a lucky mom because my children have access to the support that they need. However, my son, Tim, who is 22 and lives in his own apartment, has direct support professionals that come into his home to help him so that he can be successful in his own home, cooking, cleaning, getting groceries, staying organized, knowing what time he's supposed to be at work, all of those things. In the last 10 months, he has had 12 brand new staff brought into the home because of turnover. The staff last a little less. Sometimes they last about 3 weeks, sometimes they last 2 months. But then when there's a better paying job, they say, Tim, we really enjoyed working with you, but we need to move on. My son Tim is lucky, though, because he has a family close by that can kind of fill in the gaps when we're between staff, right? But Al is not so lucky. Al is a young man that lives up in the Upper Peninsula. He lives in Marquette. For 11 years prior to the start of the pandemic, he lived in his own home and had 24-hour support as he needed in order to be able to live his life. However, in 2020, and we don't know why, he began to experience significant behavioral challenges and mental health issues. His anxiety began to increase. Because he's nonverbal, he communicated with some pretty strong behavior, some pretty intense aggression, and he wound up in a hospital, and the provider that was supporting him just said, we can't get enough staff. We can't keep staff in Al's home. We are terminating our services with Al. And so at that time, Al was in the hospital until we could scramble around and pull together a new team of staff for him, which we were able to do in October. But then I'm not sure when it was, a short time later, Al ended up back in the hospital. While he was in the hospital, he had some staff that were not able to, not be paid, and so they went and found other jobs. And so once he was stabilized medically and on his psychiatric medication, we didn't have a big enough team for him to come home. So Al had to remain in the hospital for more than 100 days while his mother and the team that surround them up in Marquette begged and pleaded and scrambled around to find a team that's just enough to cover that 24 hours a day support that he needs, with mom filling in quite often. All it would take is one person to resign and his whole team falls apart. And then where does Al go? He can't tell us what he needs verbally. He can't cook for himself. He can't do his own laundry. He's not safe alone. He wouldn't know what to do if the house caught on fire. He needs those support professionals. However, one person resigning and his team falls apart. Well, guess what happened last night at 10 o'clock? I foolishly checked my email, and I learned that one of his staff resigned last night. And so in 2 weeks' time, Al is going to be back in a position of not having enough staff. The reason that staff resigned is because they found a higher-paying job that was less demanding, really, on them, right, physically, emotionally, mentally, than working with Al. That's the story. That's why we need to support the direct support professional workforce.
And as a final comment, and we appreciate the opportunity to testify, we don't think it's only about higher wages. We clearly need to professionalize direct support staff, direct support professionals, a statewide awareness campaign, a stronger training infrastructure, competency guidelines, credentialing. We need a number of initiatives in addition to higher wages. But at the end of the day, from our standpoint, this behavioral health system will not survive without the ability of families and providers to hire new staff. That's really our message. Thank you.
Thank you all for presenting today. We appreciate you. Next, we're going to go to Charlie Cavell, I'm sorry, Charlie, who is on Zoom.
Hi, everybody. Can you hear me okay? That. Okay? Yes?
As loud as you can go, because we can hear you, but it's not, that's it. Okay.
All right. Hi, everybody. My name's Charlie Cavell. I'm an Oakland County Commissioner, and Rep. Price suggested I come speak before you today about an issue she's been advocating for to have put in this subcommittee's budget. The request is $19 million, something with an M, or million with an M, to erase the medical debt for all 800,000 families in Michigan who are unable to afford to pay off their medical bills. I want to speak first to the problem, a little bit more of medical debt, and then second, lift up a solution we have in mind. So first, the problem. Who we're talking about when we think about medical debt, one used to include me. For example, I was in my wife's house, which we purchased together, but because of medical debt, I was unable to co-sign on it because I was not creditworthy enough because of medical debt that I was trying to outrun. So one, this is a personal issue. But second, to those 800,000 households in Michigan who are unable to afford their medical bills, they're folks that generally fall within a bracket of making 300% of the federal poverty line and below. So that means households with dual incomes. That means households with children. That means households making about $80,000 a year. So that's just a snapshot of what this problem looks like. Also, medical debt is the #1 cause of bankruptcy in this state and around the country. I want to now speak a little bit to the solution. So in 2014, a nonprofit called RIP Medical Debt, which I believe I've sent information to all of your staffs and had meetings with several of you on the subcommittee. And Chair Morse, I've filled out a budget form per your staff's request, so I hope you were able to see it. RIP Medical Debt is a 501c3 that since 2014 has been a medical debt around the country. They've worked most recently in the cities of Toledo and Chicago and New Orleans and Pittsburgh to erase medical debt for most of their residents in those communities. And this coming year, they will be also working with the entire state of New Jersey to erase New Jersey's entire medical debt for people that are unable to afford it. Michigan could become the second state to do that for that $19 million appropriation. Assuming the budget is tight, which I imagine from listening to all the testimony today, if it is the case, any appropriation amount would be a tremendous boon for our communities. And I'm speaking as an Oakland County Commissioner now, that any money you could offer from the state budget that we in our local communities could match, either our ARPA money or our general fund dollars or state revenue, any of the pots of money that local communities have access to, we would love to have the opportunity to use $1, $2, $3 million from your budget as the hook to then match the funds to then erase medical debt in our own local communities. So option one, if you are able to and willing, use $19 million to erase medical debt for all 800,000 families in Michigan that cannot afford those medical bills. Or two, provide a matching grant opportunity for us local communities to use. And this would be a one-time request that could also be ARPA eligible. And also, I just want to lift up one other thing, that the Michigan Hospitals Association is neutral on this issue. They are not against it. And so I just want to make sure that was also something brought up. And I'm happy to take questions or speak with anyone that would like to talk about this more offline, however you prefer.
Rep. Price?
Yes, thank you, Commissioner Cavell, for coming and bringing this to us this morning. I was wondering if you could also speak a little bit about how having medical debt impacts behaviors of individuals and families who have it. You mentioned how it's the leading cause of bankruptcy, but I'm also curious about how it affects people's ability or willingness to go and seek out care when they need it.
Oh, most definitely. Thank you for lifting that up. That is one of the biggest reasons why people don't seek further care, is because of either the looming threat or concern about being underinsured or not being able to afford a copay. Because also when we're talking about these families, these 800,000 families, like I had mentioned, a lot of them are working, right? 300% of poverty below. But their deductible is so high that they're unable to afford that $2,500, that $5,000 deductible to be able to then be covered by insurance. So this then allows for a lot of people's issues to exacerbate. I can speak personally to my own issues and show you some of the scars from incidents I had when I was underinsured and then also trying to outrun medical debt. But yeah, that's a huge reason. Thank you for lifting that up, Rep. Price.
Rep. Murtis.
Thank you so much for being here. Thank you so much for testifying, not just sharing your own personal experiences, but a little bit about this program. And I'm curious if you could go a little bit more in detail. Medical debt is something that all of us have experienced in our families. We just had somebody testify a little bit earlier talking about hundreds of thousands of dollars because of some things going on with her son. I'm curious, so with this plan to get rid of the debt, is this going directly to the original medical bills, or what is being done with the debt, essentially?
Yes, great question. Thank you for bringing that up. So there, with the appropriation of X amount of dollars from your committee, if you're willing and able to do so, that appropriation would go into a pot of funds that then RIP Medical Debt, the nonprofit, would then use to negotiate with hospital systems and debt collectors to collect on debt that is 90 days up to 5 years old, because that debt is most active. And what RIP Medical Debt does is they negotiate with the hospital system or the debt collector directly, and they have the pot of money to then offer an amount to purchase the debt. And then once they purchase it, they erase it within 2 to 4 weeks. And then they send a letter to everyone who's erased the medical debt saying your debt of X amount of dollars was erased by, and in this case it would be erased by the Michigan state government. They never collect on debt, this nonprofit. And also one thing to make sure I say is generally the ratio of cost of debt purchasing cost is, for example, Iota Hospital, $6,000. To purchase that debt in like the wholesale debt market costs about $600. So it's a 1 to 100 ratio. So in Michigan, there's $1.9 billion with a B in medical debt that has been deemed unaffordable because people are 90 days in arrears or further in paying off that debt. Those are those 100,000 households. That $1.9 billion with a B would cost roughly $19 million with an M to purchase. And $0 from whatever appropriation, if any appropriation is able to be afforded from this subcommittee, would go towards overhead, because RIP Medical Debt also has received over $50 million from Mackenzie Scott to help further subsidize the cost of purchasing debt and erasing it, and also pay for any administrative costs.
Thank you, Charlie. We appreciate you bringing that idea forward, and we will consider it with everything else.
Thank you so much. Appreciate you all.
And now we'll go back to Erica Winston. If you'd like to come Above and Beyond Learning Center.
She was a parent. She stepped out.
Okay. Sharon Sharp, Kids Palace. No. And Monique Snyder. Okay. Come on up and just push the mic button there.
Good morning. Thank you so much for seeing us despite the confusion that we had. That just goes to show that we are a small but mighty group. This is our first time trampling on this platform, and we are here for a reason, because not only do we need equitable funding, but we also need you to know how essential we are to the essential workers and how imperative it is for you to prioritize us within this upcoming budget. We are entities of the Department of DHHS. We are all licensed under DHHS. That's the reason that we're here right now. One of the priorities and one of the things that I want to sit and make sure that you all hear is we want to return to the step 1 hourly reimbursement rate that we got in October of 2021 is on the form that you have. We went from $4 an hour to $6 an hour, which gave us, well, I'm sorry, $8 an hour initially, which gave us a 50% increase in our hourly rate, and it also paid us on enrollment versus attendance. The reason why we are asking for these things is because right now within our industry, within the last 5 years, there's a huge impact and push for high quality. And high quality is only being measured under one measurement, the class system. I can't say I'm high quality because I have a bachelor's degree and I'm pretty good at what I do. No, I have to follow the protocol, and the protocol says high quality includes X, Y, and Z. In order for us to get high quality, we have to submit and endure circumstances that are not culturally parallel to our community. We are given 2 curriculums to choose from and a third that is out of this world, just unparalleled. Our families are being subjected to different cultural advances and expectations that we've never had to do before. We didn't get transition periods. We got, here's the new tier rating system. If you don't have high scope within your facility and your teachers aren't trained or bachelor within that, you lose points. So that's why you're getting $4 an hour now. Sorry. That's what happened to us. So what we're asking for right now is the return to the step 1 hourly reimbursement rate. Now, I'm sure that all of you are parents, if not grandparents, if not aunties and uncles. I'm asking for you all to seriously consider us getting the average rate of $9.90 an hour, because the average center on the east side of Detroit earns $9.90 an hour per child. And as Ms. Hodge eloquently pointed out, it takes two children to pay for one teacher. That doesn't include overhead, that doesn't include taxes, that doesn't include the high quality system. And John Brown does not include a bachelor's teacher. I'm a bachelor teacher, and I pay good money for my degree. I wouldn't walk into a center like my own and take $19 an hour. I wouldn't do it. But we are still held to these standards. They are still under DHS licensing requirements in order for us to get paid. We're being held under certain standards, but we're not paid accordingly. I am literally asking for funds that are they get paid more at Amazon than we pay our teachers. The reason why I decided to stay, even despite the fact that we have to sit in front of MDE, is so that you all can understand how imperative it is and how we are the foundation for these children. When COVID hit, I opened back up in May. We closed in March, we opened back up in May. I've been open ever since, working 12 hours a day with 3 children, servicing 60 to 75 children a day. Hybrid classrooms when parents couldn't go to work. We had children who were burnt at home, who were touched at home, parents coming in. I kept kids for months for free. And all we're asking for is, give us an equitable living wage. That's it. So we can pay the staff and get us what we want. This is what child care is. What's listed in that budget is not child care. Head Start is not child care. GSRP is not child care. We are child care. We are the licensing facilities. They contract with us to come in our buildings and give us a subsidy. So now we're 3-tier rating. So again, my initial request is for us to return to the step 1 hourly reimbursement so that we can ensure that we meet the high quality standards that are put in place right now that we're being held accountable for. And let me just give you a really brief, really personal situation for me. My facility was at almost 5. I was 4 points from a 5. I had a 4 point. I was very proud of myself. COVID hit. Teachers didn't come back to work. They went to work for DPS virtually because, hey, why am I sitting in the classroom with this kid when I could be home with my own family safe? It was time for me to renew my stars. I no longer had 3 bachelor teachers in my classroom. I had 2 CDAs in my own bachelor. I no longer had the opportunity to pay for insurance for my teachers. I no longer had the opportunity and the funds to put out field trips to places that they deemed necessary and academic. So when they came and did my review, guess what? I went down to a 3. Now, hear me when I say this. I went down to a 3. My funding went from $8.60 an hour for an infant. I'm sorry, $9 an hour for an infant to $8.60 an hour to an infant. My highest age group from $6.90 an hour to $6.45 an hour. Still making it happen. Still making it happen. Now, I asked myself, how are you doing this? And you want to know what I remembered? I remember when I licensed in 2009, and I went in my drawer and I saw my food stamp card. I saw my Medicaid card. From 2009 to 2013, I was a state recipient, and my building was operable. I sat at the table with the same worker that my parents sat with. I didn't get on my own payroll for the first 5 years. I know this is not going to pay the bills. And what's going to happen is you're going to take a mind like mine, who can cultivate, bring together community members, support a community, and give a valuable education, and you're going to send me packing. I'm not going back to that again, and I'm not going back in that office, especially with my level of education. It's not happening. I need you to tell them, this right here is unacceptable. This is an insult. I can send my student loans. Thank you, Madam
Thank you,
Chair
Winnie. Yeah, I
and
appreciate.
representatives.
Thank you. You've really all done a good job of highlighting that particular issue, and we'll be sure to share it with the chair of that committee.
I appreciate it.
Yep, you're welcome. Okay, we have Katie Wendell and Sally Pung from the AAA and long-term care.
Good morning. I made sure to check my clock. We're still at morning. I appreciate your time and attention today. My name is Katie Wendell. I'm the Director of Planning and Advocacy at the Area Agency on Aging 1B. We serve Livingston, Macomb, Monroe, Oakland, St. Clair, and Washtenaw counties. And today we're going to talk about the importance of adequately funding Michigan's long-term care ombudsman program. And I'm pleased to be joined here today by Sally Pung, who is our state long-term care ombudsman. The long-term care ombudsmen are a neutral third party who work with residents of licensed long-term care facilities, such as nursing homes, homes for the aged, and adult foster care homes, with the goal of improving care and quality of life for residents and advocating for the residents' wishes. Ombudsmen explain resident rights to residents and their families, empower residents to communicate their concerns, assist residents in resolving concerns, and provide education on long-term care issues, promoting best practices in long-term care facilities. In fiscal year 2022, Michigan's long-term care ombudsman supported residents by closing 3,372 complaints. There are only 20 designated ombudsmen in Michigan who are responsible for serving all long-term care facility residents. Michigan is ranked 44th among states in the ratio of ombudsman staff to facility beds. We have one ombudsman for every 5,150 beds. The recommended minimum ombudsman to staff bed ratio is one ombudsman to every 2,000 beds. In order to achieve this recommended minimum staff to bed ratio, Michigan needs to add 33 more full-time ombudsmen at an estimated cost of $3 million annually. If we make this change, our national ranking would only rise to 29th. Just to give a bit of context to where we stand in, our solution is getting us, back to the middle of the pack. Our current ombudsmen provide excellent service, but they are stretched far too thin. With an increase in funding, Michigan's ombudsman would be able to increase the frequency of facility visits conducted, support the recruitment of additional volunteers necessary to serve the population, and allow ombudsmen to be more proactive in addressing resident concerns in long-term care facilities. In addition to addressing this inadequate funding level for the program, we're also asking you to draw some attention to the funding formula that's used to distribute these funds among Michigan's 16 area agencies on aging. That funding formula is set by the Commission on Services to the Aging and was last updated in 1987. What that means in my region, we get about 16 to 17% of funding, but we have more, like around 25% of facility beds, because that hasn't had attention in so long. Michigan's long-term care ombudsmen provide a critical service to some of our most vulnerable residents, and we ask that you please consider supporting the ombudsman program and the residents they serve by adding that $3 million annually to increase the capacity of the long-term care ombudsman program to ensure we meet that minimum recommended standard. And I have a sheet I forgot to hand over, so I'll drop that off right now and hand it over to Sally.
Thank you, Katie. Thank you, Madam Chair and members of the committee. I appreciate the opportunity to come today, and I really want to talk about what ombudsmen do for residents. We can talk about all the numbers, but I really wanted to talk with you about the impact that ombudsmen have. Ombudsmen visit residents. They walk into the rooms and they make eye contact with the resident and greet them very respectfully, showing lots of dignity. And they ask the resident, "How are you today? Do you have any concerns? How are things going here in the facility for you?" And they take the time to listen to the resident, to hear a variety of concerns. Things as simple as, "They've misplaced my pink sweater. My granddaughter made that for me. It's really important to me," to more significant issues like, "I feel like I've been verbally abused by the staff," or "I've gotten an involuntary discharge notice," or "I've got this pain on the back of my bottom and I don't know what that is," and that's indicative usually of a pressure ulcer. So I just wanted to share a few stories with you today. The pink sweater is really touching because that connected that resident to her family and to a loved one who she wasn't seeing anymore. It's challenging when you go into a long-term care setting. You give up a lot of control over things in your life. You give up a lot of your community. And what you have left are, fortunately, the staff who show up every day and try to take care of you and meet your needs. And ombudsmen help support that. We're that unbiased, resident-driven person who's there to help advocate and strengthen that resident's voice to say this is what the resident needs. One example, we had a resident visit where the resident said, "I really want to eat, but the facility's telling me it's too risky for me if I try to take anything by mouth." Well, our ombudsman, after working with that resident, got that resident a new assessment through the speech pathologist. They're doing some specialized new treatment, and she's able to eat now by mouth. But even more importantly, that resident was able to get rid of her healthcare power of attorney, the activation on it, because she's capable now of making her own decisions. And she was, being limited in her rights and in her decision-making by having physicians still honor that healthcare power of attorney that was no longer needed for this resident. The resident's thriving. She's eating food that she enjoys. And the most recent update that we heard about this particular resident is she's been referred to the My Choice waiver program. We heard about that testimony about that program earlier. And with the help from the ombudsman, she's met with the intake staff, and they're looking at getting her transitioned back to the community. And think about what that means for her. She's back at home. She's in control of her life again. She's eating the food she enjoys. She's not dependent on staff as much in that restrictive 24-hour setting. I wanted to share with you through the pandemic some of the things that we advocated for. Visitation was a big one. We knew there was need to limit visitation to keep residents safe, but there became a point in which it was safer and we could take precautions. And to this day, we are still advocating for residents to have the visitors of their choice, which is in the federal regulations. It's a right that they have. We've came across many residents who complained about their personal hygiene. Some residents reported to us that they had not been offered a shower in months. Some of our ombudsmen reported that their shoes stuck to the floor because the rooms hadn't been cleaned. We know there was a pandemic, but imagine living in that kind of condition. So our ombudsman tried to work with facility staff to say, how can we get back on track? How can we make things better for residents? It's a dignity issue. To have a visitor come in and stick to your floor is a dignity issue for them. That's their home. That's where they're living. Another one that continues, and it was even prior to the pandemic, are wait times. You know, in nursing homes, they have a call light button that they hit, and they wait for staff to respond. We've had residents tell us, and we've had ombudsmen actually observe, that those lights sometimes stay on for hours. And that's the residents' lifeline to help. That's how they get their needs met, is by pushing that button. Some residents have come up with unique ways. Some of them pull that out of the wall, and that sends more of an emergent message down the hallway. One resident actually, because the staff weren't responding to his roommate, stripped off his clothes and stood in the hallway naked. And when the staff asked why he did that, he said, because my roommate needs help, and that's how I knew I could get someone here to help him. So I don't mean to say those things to you in a way that it disparages our nursing homes. There are a lot of people out there every day trying to provide good care and good work for residents. But we have a unique role in which we can talk with residents, we can listen carefully, we can help resolve those issues. We can go back to the resident's care plan and say, how can we meet this resident's need? How can we make sure that they're on the shower schedule and that staff approach them in a way that encourages the resident to want to go down to the shower room and be showered? I just wanted to also share, I know we're short on time, but we've had a few cases recently where we've helped fight residents that have received an involuntary discharge notice from a nursing home. These were residents that were not conducting themselves in a way that it violated any of the reasons for them to leave a nursing home. The nursing home just didn't want to work with the resident any longer, unfortunately. And we were successful. Those residents had the opportunity to stay in what they considered their home, where their new community is at, their friends are there. That's a hard thing to do, to win those cases, to advocate that a resident has the right to stay in those homes and shouldn't be involuntarily discharged. And we even had a few cases recently where we've helped the resident remove a guardian that was no longer needed. At one point in their health crisis, the court appointed a guardian appropriately, but as the resident improved, there was no longer that need to have a guardian. And to think about that, to have the court say to you, you're not capable, you don't have capacity to make decisions, and then to improve and restore yourself back to full capacity and still have that document and that person making decisions for you. And we were able to connect those residents to legal resources, go before a judge and argue that the resident, we didn't argue, we only advocate for the resident, but to have that case go before a judge for that resident to be restored and to have your rights returned to you and feel like you are a whole person again, I don't know what could be a better outcome for residents and for ombudsmen to be able to advocate. But I just wanted to share with you, our services are available to all residents in long-term care settings. There's not any requirements for payer source or your finances. The fact that you're a resident is in those settings means that we're available to serve you. We need more ombudsmen so we can be out there more frequently, meeting with those residents, knocking on the door and saying, how are you doing today? Because that's how we find out what are the concerns and how can we help the resident resolve the concerns that they have. So thank you again, and I appreciate the time today.
Thank you.
Thank you both for being with us. Okay, next we're going to call Kelly Steppel, who is joining us on Zoom.
Good morning. My name is Kelly Steppel. Are you able to see me?
We can't see you, but we can hear you.
All right. How's that?
Now we can. Go right ahead.
Okay. My name is Kelly Steppel, and I'm the child health advocate with Success by Six and the program manager at the Washtenaw Health Plan. And I'm here today because we wanted to thank you all and the governor for, in the proposal, adding funding to eliminate a 5-year waiting period for Medicaid and the Children's Health Insurance Program for lawfully residing immigrant children and pregnant women in Michigan. And we're encouraging an increase encouraging you to support this increase. But we also wanted to remind you that an important group has been left out of that increase, and that's undocumented immigrant pregnant women. They are eligible to have the mom's insurance coverage through the Department of Health and Human Services as part of their emergency services Medicaid. But at 60 days postpartum, they lose that postnatal coverage that they got through moms. This coverage has been extended for women who are active for full Medicaid, but not for women who have emergency Medicaid in the moms program. So we're encouraging that the governor and the legislature add coverage for an additional 10 months postpartum for undocumented immigrant women, which will give them a full 12 months of coverage after the month that their baby or babies are delivered. And then one possible mechanism for funding this is through the CHIP Health Insurance Initiative. This HSI funding could potentially cover the cost of this expansion without using additional state dollars. Illinois, Minnesota, and California have all successfully utilized this funding in that way. And we hope that the subcommittee and interested legislators will work with MDHHS to learn about the amount of funding that we might be eligible for to help establish this expansion. And part of the reason that we're interested in doing this is because even though these women do not have what's called eligible immigration status, they will be giving birth to U.S. citizen children here in Michigan, who will be, full citizen residents of our state. And we would like for these children to have the best start in life that they can. And the way that we can help newborns have a good start in life is to help their mothers have adequate postnatal coverage. And so by expanding this coverage, women will be eligible for things that they wouldn't otherwise qualify for, such as anything that we would relate to their post-pregnancy diagnosis. So medication, including things like contraception, which might not be an obvious benefit to women who are pregnant, but one of the things that we know is that studies have shown that effective spacing of children helps maternal health, and it also helps families be more sustainable. So if we can give women access to things like contraception as part of this expansion, then they will be able to plan their families more carefully and support the babies that they do have while waiting to have babies at a later date. So I'm hoping that you will consider adding this funding for undocumented pregnant women, and thank you all for what you've already done.
Thank you, Kelly, for your testimony today. Next, we have Stephanie Hall from the Silver Key Coalition.
Good morning. Chairman Morris and members of the committee, my name is Stephanie Hall, and I am the Research and Advocacy Manager at the Erie Agency on Aging 1B. I am here today representing the Silver Key Coalition. My agency serves Region 1B, which consists of Livingston, Macomb, Monroe, Oakland, St. Clair, and Washtenaw counties. This region alone has experienced a 32% increase in older adults since the 2010 census. Region 1B is not alone. Counties across the state continue to experience tremendous growth in the older adult population, with the 60-plus population growing by 33% since 2010. Michigan continues to age faster than many other states, with Michigan currently being ranked 14th in the percent of the state's population that is over 65. In 2017, older adults in Michigan, for the first time ever, outnumbered school-age children. According to the 2021 ACS, Michigan has just over 2.4 million older adults. I am here today representing the Silver Key Coalition, which was founded to advocate for increased state support for non-Medicaid senior in-home services provided through the Bureau of Aging, Community Living and Supports, or ACLS Bureau, within the Michigan Department of Health and Human Services. The coalition's membership of over 40 separate organizations are united for the goal of securing state funding to eliminate wait lists for services often needed by older adults to age in place in their homes and communities. This population has income and savings just above the poverty level, meaning they make too much to qualify for Medicaid services, but not enough to afford the high out-of-pocket costs for care, making them sometimes some of the worst off. At the end of fiscal year 21, there were 7,270 individuals across the state on wait lists for ACLS in-home services. These services include personal care, homemaking, home-delivered meals, among others. These services support the work of family caregivers and enable older adults to remain in their communities, often preventing or delaying the need for more costly state-funded Medicaid interventions. We project that addressing the unmet need and anticipated increases in demand related to the older adult population will cost $10 million. Increased state funds allow area agencies on aging across the state to leverage local support and donations from program participants. With that leveraging in mind, the Silver Key Coalition is requesting $9 million for in-home services and $1 million for home-delivered meals in the ACLS Bureau fiscal year 24 budget. Addressing the unmet needs of Michigan's older adults should be a priority. Significant population growth, the shortage of direct care workers, and increased inflation have put strain on Michigan's aging network. We need your help to keep pace with our community's needs. Silver Key Coalition members recognize that you have difficult choices to make in this budget process, but please remember that these in-home services have proven they reduce nursing home admissions, reduce family caregiver burden, and increase life expectancy of those who are served. We ask for your continued support to meet the unmet needs of our aging population. Thank you.
Thank you so much for your testimony today. Appreciate you. Next, we'll call up Cindy Roper from the Natural Resources Defense Council.
Good morning, and thank you so much for the opportunity, Chair Morse and members of the subcommittee working hard over your break. Really appreciate the effort. I'm representing the Natural Resources Defense Council, which has a long history of working to strengthen the nation's drinking water protections, including efforts to eliminate lead and PFAS from drinking water. And I've been working on these issues for many years in Michigan, and also I'm a former member of the U.S. Environmental Protection Agency's National Drinking Water Advisory Council. Most recently, I've been working closely with the People's Water Board Coalition and with Flint Rising and the Benton Harbor Community Water Council to address issues of lead in drinking water and also water affordability and preventing water shutoffs for people throughout the state. I want to start by just saying we support the executive budget recommendation to include funding for water filter distribution, but we also request that that money be made available for bottled water. What we found in Benton Harbor is that there were many disruptions in the water system that also helped potentially release microbials into the system, and filters are a wonderful breeding ground for bacteria. So we just would like to have that flexibility with that fund, if possible, to ensure that communities are able to access bottled water if that's what they need to protect their health. We also support the recommendations of funding for local public health departments to respond to drinking water problems and for monitoring drinking water contamination. So appreciate those being included in the budget. But I really want to focus on the efforts to address water shutoffs and to make sure that water is affordable. As we all know, water bills and rates across the state are increasingly difficult for low-income households to afford, and when residents can't pay their water bill, they can be disconnected from their service. They are also at greater risk of public health or of health problems, and they can have their children removed from their home by Child Protective Services. Also, water utilities lose revenue when people can't afford their water bills. And historically, the impacts of water shutoffs and unaffordable water have been neglected. I know I worked for decades to make sure drinking water was safe, and I wasn't focused on water affordability. So really, through working with the People's Water Board Coalition and Michigan Welfare Rights Organization, two groups that have really been at the forefront of elevating the affordability crisis for nearly 2 decades. And they've led the charge alongside former Representative and now State Senator Chang to propose solutions that are embodied in separate legislation. So we appreciate the legislature including in the January supplemental budget $25 million to help prevent shutoffs, and we welcome the governor's proposed $40 million for this purpose. However, We are here to request an additional amount to fund both water arrearages as of a certain date for residents that are at, say, the 200% of federal poverty level, and then also to help meet the cost of service of water utilities that have implemented water affordability programs, like the program developed in partnership with community members by Oakland County Water Resources Commissioner Jim Nash, that basically establishes residents are not to pay more than 3% of their income for water services. And that approach has also been adopted by the Great Lakes Water Authority for nearly the entire service area. However, they do not have long-term funding for that program, and we really would like to support efforts to, in the short term, create an interim funding source that allows these water utilities to continue with these affordability programs while we separately and apart work on establishing a sustainable funding source. So in the interim, what we are requesting is that the amount that's earmarked, and we believe at this point it's 25 plus the 40 million, be increased to 250 million to again take care of the arrearages, people who are behind on their water bills that are at risk of having their water shut off, and then also to help seed fund an affordability program that would get in place programs that are allowing residents to pay for their water bills. So I appreciate your allowing the opportunity to speak today, and I'm available for questions. I will submit written testimony as well, but wanted to be sure to take the opportunity today.
Thank you so much for being with us today. Next, we have Ellen Hyman from the Michigan Oral Health Coalition.
Good morning. Good morning, Chair Mars, and the rest of the committee members. I appreciate you taking the time to hear testimony today. I'm Ellen Sugar Hyman. I'm with the Michigan Oral Health Coalition. We're a coalition of organizations, advocacy organizations, payers, providers, advocating for optimal oral health for all Michiganders. And I first want to say just how wonderful it is that in the last fiscal year, there was an expansion of adult Medicaid dental. Not only an increase of rates, which hadn't been increased for 30 years, but an expansion of services, and to include restorative care, such as root canals, periodontal care. And we really think that this will increase the overall health over time of people on Medicaid, decreased heart disease and diabetes. We're also optimistic that this will decrease emergency department use. There's about 50 for dental. There's about 50,000 visits each year. Most of those are people on Medicaid for dental pain and infection. So I really just wanted to say today that we will hope the appropriations for this next year will be sufficient to meet the need. It's kind of a moving target because the expansion of the service rate just started 2 days ago, and the service rate increases started January 1, so I'm not sure what the right appropriation is, but we just wanted you to be mindful of that. The other moving target is how many people will be eligible for Medicaid because of the end of the public health emergency. But we just wanted to just share that we really value the appropriations that were put forward in this fiscal year, and hope to continue to fund that in the next fiscal year at sufficient levels so people can get the services they need.
Thank you, Ellen. We'll certainly be paying attention to that and see how we do as a state and see how much more dental care we're able to provide as a result of that really monumental change last year. So thank you for being with us.
Thank you.
Next, Sarah Prout-Ronnie.
Good morning. Thank you. Thank you, Madam Chair, for continuing this testimony. I'm Sarah Prout-Rennie. I am the Executive Director of the Michigan Coalition to End Domestic and Sexual Violence. I'm from Berkeley, and I am grateful to be here this morning to speak to you about domestic and sexual violence across the state of Michigan. Thank you also for sitting through this morning. I heard all the emotional testimony. Thank you for your service overall. None of these decisions have to be easy. I have been an attorney, a victim's rights attorney. I am the mother of a survivor of sexual assault for over 25 years. I was benefited from services and also believe strongly in the services within our state. I became executive director of the Michigan Coalition 8 years ago, and we are a coalition of all 73 domestic violence and sexual assault programs. There is one that covers every county in the state of Michigan. Our programs provide not just shelter, but crisis intervention, supports, long-term supports, and basically are the first responders to every type of victim of crime. I can tell you as a mother of a sexual assault survivor, a child sexual assault survivor, this is not a one and done crime. Folks in my movement and in my coalition see and care for people both in the short term and in the long term. One of the things I wanted to bring to your attention is for all the 25 years that I've worked in this field, the last period, the period since the COVID pandemic has been the most brutal and the most challenging for my programs. You've sat through many different ways in which our systems are not working. Our programs, who are not law enforcement, they're not mental health, they are nonprofits, are seeing, they're the first responders to that systemic failure. Not only is there more violence, there are more survivors with co-occurring mental health issues that can't get the care they need, and there is more need, and during the pandemic, there was less capacity. We have always been underfunded. We could never compete with Burger King in terms of our ability to pay our staff. Now, we are facing an absolute critical moment. We are asking the state to invest in serving victims of crime. Every other Great Lakes state, Ohio included, has committed general funds dollars to domestic violence and sexual assault shelters. The over-reliance on the criminal justice system's fees and fines, which we are now finding to be completely unstable, was seen and addressed by most of our sister states before we hit this crisis. So I want to readdress, because one of the things that keeps coming up is how much will we be short? The truth is we were short before this. There was no investment by the state, and the state can't tell us from year to year what the shortage will be. So we are unable to plan to support victims of crime in your communities, and our programs are at the breaking point. I have sat through, myself during the pandemic, executive directors who are working 20 hours a week and taking the night shift and responding to crisis calls and trying to deal with the grant compliance issues. We're hemorrhaging people. People have died during the pandemic. There are perpetrator violence is increased, and there's no money for staff retention. We are not just asking for this to be an address to the shortfall that DHHS may be projecting because of fines and fees. We are asking the state to do a full commitment to victims of crime who are domestic violence, sexual assault, and trafficking survivors. And I want to say a minute about, because we are working with our sister coalition, the Child Advocacy Centers. My child benefited from going to the Child Advocacy Centers. From birth to death, victims of crime deserve support in this state, and we don't have it. And our sister coalition is equally in need, as we are, as our programs are. This is a crisis. We need your support, and we are asking for the same supports that other states have already begun to do, because the only projection we have is fees and fines are going down. And if you know the arrests and prosecutions, most felonies aren't even being heard for 2 years. So we know this problem is going to just continue to be a problem. And women and children and other victims come to our shelters and we are the baseline of support, and we need to be able to help them.
Well, thank you so much for your testimony today. We've heard it, and we will certainly take it under consideration.
Thank you.
Our last card that we have for now is Brian Tarrant. There's no organization listed, though. Nope. Do we have anyone in the room who is interested in testifying but hasn't been called up yet? I did want to note that we have several written testimonies provided by organizations including MPLP, the Dental Association, Access, and Shelter. And those will be provided to all the members of the committee. We do have an addition to Zoom. We have Jamie Worker. Jamie, you can join us.
Zoom. Able to share still?
I'm sorry, Jamie, we cannot hear you or see you.
Can you hear me now?
Yes, we can. Go ahead.
Oh, can you hear me now?
Yes.
Okay, thanks so much. Good morning and thank you to Chair Morris. Wonderful. Good morning and thank you to Chair Morris, Majority Vice Chair Martis, Minority Vice Chair Green, and all the members of the House Appropriations Subcommittee on Health and Human Services. Really grateful for the opportunity to provide public comment today. My name is Jamie Worker, and I am Associate Director of Policy and Advocacy at Caring Across Generations. So Caring Across Generations is a national campaign of family caregivers, care workers, people with disabilities, and aging adults working to transform the way we care in this country so that aging and disability care, paid leave, and child care are accessible, affordable, and equitable. And our systems of care enable everyone to live and age with dignity. You'll hear from my colleague, Callie Bruley, after I share my own testimony. Over 88% of Michiganders want to live and age in their own homes and communities. And in Michigan, about 1 in 4 people have a disability that makes it difficult to do everyday tasks or other activities needed to live independently. Medicaid, home and community-based services assist disabled people and older adults with day-to-day activities such as getting dressed, preparing meals, taking medications, maintaining their jobs, and using transportation. However, the lack of family-sustaining wages and benefits in the direct care workforce makes it difficult for people to get the services they need at home. And instead, people are forced to go into institutions such as nursing homes. Home health aides, personal care aides, nursing assistants, and direct support professionals are all examples of direct care workers that provide essential care services for people with disabilities and older adults. The governor's budget includes modest support for direct care workers, increasing wages by an average of $1.50 an hour. This is a very welcome increase, and it's also not enough to stabilize this critical workforce. Any wage increase must guarantee that care workers are paid at least $18 per hour or an average increase of $4 per hour. This wage increase must include direct supervisors as well, who are often providing direct care support themselves due to staffing shortages. We know that the workforce shortage is actually a shortage of good jobs. Too many care workers are forced to leave the jobs they love because they simply cannot afford to do this essential work. Currently, Michigan direct care workers are paid an average median wage of $14.76, so above the minimum wage of $10.10, but still well below a living wage. And because workers are underpaid, more than 1 in 4 direct care workers are eligible for public assistance. We know that the economic barriers direct care workers experience are the direct result of historical and present-day policy choices that undervalue care work, exclude these workers from basic job protections, and result in inequities experienced by this workforce of disproportionately Black women. The vast majority of the services provided by direct care workers is funded by Medicaid at rates that are set by the state or constrained by the rates paid to managed care organizations. The rates providers receive, most of which goes to pay direct care workers, do not take into account the wages of competing occupations, the need for benefits, and the actual cost of services or adjustments to minimum wage. This means that wages have been essentially flat for decades without adjustments based on inflation or cost of living increases. Raising wages of the direct care workforce is a cost-effective strategy. This will lower out-of-pocket costs for those who need care, enable more people to receive services at home, support employment for family caregivers, taking time out of the paid workforce to care for their loved ones, and create thousands of good direct care worker jobs. The lack of family-sustaining wages and benefits for direct care workers also leads to high rates of turnover and means that many of these jobs are going unfilled despite the growing demand. The direct care workforce in Michigan has a turnover rate of 42%, disrupting the critical care and services for older adults and disabled people needed to remain in their own homes and communities. And turnover in this workforce is estimated to cost the state $684 million, which is nearly 6 times Michigan's entire senior support appropriation in prior years. Care work is the work that makes all other work possible. And by investing in care, the Michigan legislature will bring us closer to ensuring all Michiganders have the care that they need, family caregivers are supported, and care jobs are good jobs. Thank you. And I'll pass it over to my colleague, Callie Bruley.
Thanks so much, Jamie, and good afternoon, everyone. Thanks for having the hearing today. My name is Callie Bruley. I am here today as a senior campaign manager for Caring Across Generations, which, as Jamie said, we're an organization working to change the way we give and receive care in our country so that all can live and age with dignity. But I'm also here as a family caregiver who helped provide care to my dad alongside my mom and direct care workers throughout his life with Parkinson's disease, and now for my mom, who has her own health challenges, many of which are due to not having access to the support that she needed at the time when she was my dad's primary caregiver. And so I too would like to speak to the modest average $1.50 per hour wage pass-through for direct care workers included in Governor Whitmer's proposed budget. While obviously this is a welcomed increase, it is nowhere near enough to meet the needs of Michigan's communities. Any wage pass-through must guarantee that care workers are paid what they deserve. That would be at least $18 an hour or an average increase of $4 per hour. And we also believe that this must include direct supervisors as well, who are often providing direct care support themselves due to the staffing shortages. The foundation of a strong economy is a strong care economy, and the beating heart of a care economy is care workers. Michigan needs more care than ever, but the workforce is in crisis. A direct care worker shortage, which really is caused by low wages and poor benefits, harms everyone in the state. not just the workers themselves, but also especially family caregivers, disabled people, and aging adults. These essential workers provide life-saving care that allows our families and communities to thrive, but they have often been left out by government investments. And so just to speak a little bit more to how the workforce crisis is not only impacting the workers, but also impacting the people they provide care and services for, as well as their families. When there's a workforce crisis, families more often than not, end up filling in the gaps for themselves, or will need to make the impossible choice of leaving a paid job to provide unpaid care. It's time for a long overdue investment in Michigan's care system so that our families don't need to face financial ruin to access care and can go to work knowing their loved ones are cared for safely in their homes and communities. So we simply can't wait any longer to transform the care landscape so everyone can live, work, and age with dignity. And so, and just to close us out here, we all will need, provide, or receive care at some point in our lives. And care is something that unites us all. And often it happens in really unexpected moments. So that's why we need this investment so our state can be prepared. And so we really ask that Governor Whitmer's proposed budget is the floor, not the ceiling, of investments this year to address the direct care workforce shortage that's affecting communities across Michigan. So that's why Michigan leaders should appropriate at least $215.6 million. This would provide $4 per hour wage increase to direct care categories that provide both behavioral health and long-term care services. Or if it's helpful, that would be the workers who received the $235 per hour wage increase in 2020. Thank you so much for your time.
Thank you, Jamie and Callie, for your testimony. Anyone else out there waiting to testify? Okay. Well, with that, Rep. Price moves to approve the minutes of March 22nd, 2023. Hearing no objection, the minutes are approved. Rep. Price also moves to excuse absent members, and hearing no objection, absent members are excused. And seeing no further business before this committee today, this meeting is adjourned.